3, 2, 1. Please start. We are live.
We're going to give it about 20 seconds, faculty. Let's go ahead and mute everybody except me and Debraj for now. Okay, well, we are live here on planet Earth all together. My name is Tanuj Nakra. I'm in Austin, Texas. On behalf of myself and Dr. Debraj Shom in Mumbai, India, we would like to welcome you all to the third Global Cosmetic Surgery International webinar. Over the last year and a half, our world has been through turmoil. One of the bright lights in this difficult time has been the advancements in international webinars, and we've been pleased that this organization of Global Cosmetic Surgery has been able to bring to you now 3 free live webinars on facial cosmetic surgery. And today, we're thrilled to have a specialized series of lectures on the lips and the nose, both non-surgical and surgical management of the lips and the nose. And so on behalf of myself and Debraj, we'd like to welcome you to the session. And we'd like to let Dr. Debraj proceed with further introductions.
Thank you so much, Tanuj. Thank you to all the wonderful faculty who've joined in from different parts of the world. For some of you, this is very early in the morning. And for some of you, it's very late in the evening. Thank you for making the time to come in and try and teach delegates from across the world. It will gladden your hearts, and it also gladdens our hearts to have 2,500 delegates logging in from over 30 plus countries today. And this has been the way with the Global Cosmetic Surgery meetings. The first couple of meetings also had approximately 3K people logging in. And it's a matter of great pride, privilege, and honor to be able to train and have so many wonderful faculty talk to these people directly. And that's, I think, one of the big advantages of this technology-driven pandemic or post-pandemic work. My job will be incomplete without thanking everyone who's logged in now. It would also be incomplete without thanking the aesthetic clinics and the TOC teams, which have been working behind the scenes for the past 3 weeks to try and put this together. It would be impossible to have this meeting without our fellows, Dr. Monica Surana, Dr. Arundha Abrol, Dr. Donovan Reed, and Dr. Monica Ray. Thank you so much for participating and making this meeting a success and coordinating with the faculty and dealing with the mood swings of Tanuj and myself. The tech team, Swarnim Touch, has done a wonderful job, and thank you so much for being here. And the design team, RioCon, has been instrumental in making sure all those irritating emails have been going out to people all across the world. The sponsors of this particular meeting, as can be seen on the Zoom background, are Avia Skincare, which is a company which is, and Tanuj will speak about it in his financial interests as well. It's a company which is led by Tanuj. And then the QR678, which is a formulation for causing hair growth, which I will be speaking about in our talk. A reminder to also remember that there are 5 gift hampers which will come in from Avia and the QR678 team. And a reminder to follow at Avia Skincare on Instagram, as well as at Global Cosmetic Search and at QR678.India to win an early bird prize. Thank you so much once again. And we are on with the scientific session right away. Thank you.
And so I'd like to go ahead and now introduce Julie Woodward, who probably does not need an introduction to the world, but in case you didn't know who she was, she's a professor of ophthalmology at Duke University, and she has been a renowned lecturer around the world in facial aesthetic surgery and fillers. And so she's going to go ahead and take the stage now. Julie, please go ahead and start with the non-surgical lip session.
Julie, you're muted at this moment. Would you please unmute yourself?
There we go. Is that better?
Yes,
Okay.
perfect. Go ahead and start now.
Thank you. Okay. Tanuj, thank you so much for the invitation. I am very humbly excited and thankful for the opportunity to moderate this session. And this is definitely an interest of mine, as well as surgical rejuvenation of the lip, which is the next session to follow, which I'm sure is going to be outstanding. So I would like to introduce our moderators and our speakers. So first we have Dr. Achima Shrawinda, and she's from Thailand, a very famous dermatologist and Mohs surgeon. And she did some training at Boston in the United States. And she's a very active member of DASL, which is the Dermaesthetic Surgical International Association League. And then she's on the board of numerous aesthetic editorial boards and journals, and will be a tremendous moderator for this session. I believe I've heard her speak at MCAS. Then we have Dr. Dong Noi Li, who's from China and has 7 years of dermatology experience and has been doing research for the past 20 years. And then we have Dr. Shino Bay, my dear friend of many years, and he needs no introduction. He has 100,000 or so followers on Instagram. And we first met in Ireland. We were the first group of physicians taken to see where Botox is created. And not only is he world famous for his lecturing, but he introduces himself to everyone as their best friend. You actually feel like he's such a warm person. He's so special that you just feel like instant connection with Shino, and it really comes through on his Instagram. Then we have Dr. Chaitra Anand, and she also is a very good friend of mine that I met through another company. Galderma took us to lunch together many years ago and said we'd be fast friends, and we absolutely were. And every time we meet up at a conference together, we create a special lunch. She's a dynamo on Instagram as well, with over 90,000 followers, and has a chain of clinics called Cosmoderma through India. And she has amazing posts constantly on Instagram. Then we have Michael Gold, another friend of mine for 10 years, through a meeting that we attend called the Cosmetic Surgery Forum. And we've injected live on stage together on numerous occasions. So we either assist each other or inject. And he runs probably the largest research clinical trial center for both devices and fillers, as well as a busy dermatology practice. And he's a dynamo, not just at his research, but he's given me many lessons I try to take in learning how to delegate better. So then we have Supra Vadera, who is from Mumbai, and she is a rising star in rhinoplasty and facial plastic surgery. And she works at the Aesthetic Clinic in Mumbai. And I'm really looking forward to her talks as well. And she is qualified to run many dermatologic clinical trials. So that's our group for this session. And so please take it away with our first speaker.
So Sheena, we'll have to have you unmute and go ahead and screen share, and we'll get started.
Perfect. Thank you, everybody. Let me share my screen in just a second. And let's go to the presentation. How's everybody doing this morning? I am blessed to be here with all of you and this amazing faculty. And let me, well, just a second. Technical difficulties. Here we go. Again, thank you everybody for having me here. This is an important meeting for me because I see the quality of the faculty that show every year, and I never get a chance to learn when I go to meetings. And on this one, I actually sit here, listen to everyone, take notes, and trying to share this with my residents. I'm gonna be talking about the lips, since this meeting is all about lips and lectures from all over the world regarding these areas, which are important. There are important areas in the human face. These are my disclosures. I speak for pretty much every company that have injectable fillers. I do that because I don't want to be accused of being biased. I don't sell syringes or fillers or vials. I just can tell you what I do with certain products from these companies with my hands. So, trends of lip augmentation. There's a lot of trends out there, and I'm kind of like a trend observer. I'm not a trend setter or a trend follower. I like to observe and see which way things are going. If things are going favorable, to elevate the aesthetic industry. I participate if I feel that these trends are detrimental to the aesthetic industry and to our youngsters out there. You'll hear from me. So we know that lips, just this, a few areas on the face that are sign of youth, beauty, and fertility. Centrally, we know that the nose, the lips, and the chin are sign of youth, beauty, and fertility, and lateral, the cheekbones and the ramus of the jawbone. If you can enhance and improve these areas with injectable fillers or whatever technique you have in your armamentarium to make people look more attractive, you will achieve your goals. But since I'm talking about lips, let's talk about some statistics. Lip augmentation has increased about 5% since 2016 and 43% since 2000. Every 20 minutes, a lip procedure is done globally in the world. Global lip augmentation is about $2.2 billion and expected to grow about 9.5% from 2020 to 2027. Overall, soft tissue fillers have increased 312% since the year 2000. And we all know that Kylie Jenner had a major impact on millennials. Before her, most of the lip fillers that we were doing were a little bit were done on older people. She shocked her fans, though, by announcing no more lip fillers in the mid-2018. Now, most of the patients now these days are going at least in the area where lips, trying to go to more natural. They don't want the lips to look overdone or stiff, and they want to look like themselves, but just better. Yes, we know that there's this trend about the Russian lips, which I tend to really go against. I have nothing against having larger lips, as long as those lips look like they belong on that face. The ratios and proportions of the lips needs to complement the patient's face and the race or ethnicity of the patient. So lips are very complex aesthetic feature. They may not look like they are, but they truly, truly are. The lips should have the width of the inner irises or the medial borders of the irises. The lips with a uneven fissure are considered less attractive than those lips that have a more straight, even fissure. That's why the M lips are a little bit more difficult to work with. And most people with M lips want to get rid of the irregularity on the fissure, trying to make it more linear. The upper lip should be slightly anterior than the lower lip, with a similarity of the shape of the nasal bridge when you look at the face laterally. Also, a good philtrum column is a good sign of a good upper jaw or maxilla development. Now, this 1/3 to 2/3 lips or 1 to 1.618 ratio, or the golden ratio, is something that we're taught constantly in aesthetics. But by now, we all know that this is only good for Caucasian descent individuals. African descent individuals is about 1 to 1. Latino, Latinx, of Native Indian or Asian, we have different ratios. Now, we need to be aware of unconscious bias. For example, everybody that is on the panel and everybody that is watching, let me know who of all these lips, which one you consider the more attractive. For me, and I think when I give this lecture, most people say that F is the more attractive lip. So again, we all have our biases, unconscious bias, but we all sometimes can agree about what is the more attractive lip, but it's not the lip itself. We are looking at the lip, but our eyes are also measuring and trying to see what other features complement that lip size to bring harmony to the face. So the perfect amount of lip augmentation is very personal. Preference depends on ethnicity and the region. For example, in Asia, surgeons prefer greatest degree of lip fullness, while in Europe, surgeons prefer the lowest degree of lip fullness. So again, everything has to do with where you are, the desire and the intention of the patients. And we know that the younger patient population, they are more impressionable and they tend to follow trends when it comes to lip augmentation. So again, I mentioned earlier that the lips are a very complex aesthetic feature. Look at the amount. We have all this type of, just on the upper lip, we have 8 different regions and 7 on the underlip. So there's 15 zones for lip anatomy. They are not so simple. And again, when we do them, we need to understand the anatomy that comes with it. The superior labial artery mean external diameter is about 1.8 millimeter, and it originates above the labial commissure about 80% of the time. When we compare it to the lower lip, the inferior labial artery mean external diameter is slightly smaller, about 1.4 millimeters, and it originates below the labial commissure about 43% of the time. The horizontal labial artery, HLA, and a vertical labial artery, VLA. And if you have seen some of the lectures of Sebastian Cotofona, you know that when we put that needle into the upper or lower lip, we are just within a few millimeters of error every time we inject the lip. Now, this lecture is all about lips, but I wanted to take the opportunity to talk about the aging lips, not just the lips that we do for enhancement, the younger generation type of lips to bring more beauty, prejuvenation or beautification of the lips. I want to talk about those lips that I used to ignore just because I thought they were difficult to do or because I thought the patients weren't interested of doing. The aging lips are very important because when you're young, I have yet, whether you have thin lips or big lips, seen an ugly lip on a young person, unless they're being modified or injected with, injectable fillers with poor techniques. Usually, whether you have thin lips or big lips, if you're young, you will always have beautiful lips. To demonstrate this, I use this computer, this application, where it shows me as a 19-year-old, me, the way I look now, and me, what I will look when I'm 80 years old. And you can see that most of these computer changes are by a few millimeters on the size of the eyes, position of the brows, but the most dramatic change are on the lip, which are by about 3 to 5 millimeters in change. Meaning that if you have somebody that have loss of architecture of the lips, especially if it is a female, you are robbing their sense of attractiveness, because lips, whether you're male or female, are sign of beauty, fertility, and youth. And we have an example here. This is the type of patient that I will neglect because I thought that they probably weren't interested in doing anything. And in fact, most of them didn't want to do that because they were afraid of the type of lips they saw on the past. Tense lips that were over enhanced with products that didn't have the right type of rheological properties for them. We see another lip, just a small little enhancement, especially on the lower lip, can make a woman feel more beautiful, more attractive. And these are the type of lips that I was neglecting just because I didn't have the right product for this type of patient. Now, I just throw this picture in here because she's a young patient, but you can see that whether you're young or older, a nice enhancement of the lips can make a world of difference. So when did I start changing my idea of not treating this older patient? I'm talking about 65, 70, 80s, and 90-year-old patients. Well, until this product came into my hand. So let's talk about a little bit about this product. We know that all HAs are basically created equal up to 1 point. So they all come in a powder form. We bring into solution by adding water. Then we add BDDE to cross-link, And voila, we have an HA that's not going to disappear within 24 hours. Now, the next step is where all the company have their own proprietary formula. This product is a product that is created with wet milling of the gel. And by wet milling of the gel is they get the gel created and they push it through a mesh. And if you do it while the gel is wet, you're gonna get these X-linked HA particles that are very smooth, round, circular, and they tend to create less problem with inflammation. To this, they added this linear HA to the solution, then they sterilize it, and voila, you have this wonderful product. Why do I like it? Because the spherical shape of this HA makes it very smooth and uniform. And when you inject it, you can inject right at the GK point, and you see the product flow smoothly all the way to the oral commissure, which causes the product to be ideal for very difficult lips to do, like aging lips or M-shaped lips, and lips that are lost their own architecture with the passing of time. Now, why is this important? Well, there's other products that are created the same. They are pushed through a mesh, but they are put through a mesh while they're dry. And this causes molecules or particles of this HA to be ragged. And when you have jagged edges, then that increase inflammatory reaction. The best idea is using a cream that have spheres for microdermabrasion, or sand and you rub your hand, or using a very smooth cream. If you use something with ragged edges that can make rub your skin in the wrong way or too aggressive, that is going to cause inflammation. So this product, when it came into my hands, when I started using, I realized that now I have something that has the right rheological properties in terms of G prime viscosity and the smoothness that I needed to do lips on very old individuals. So this product also comes with this TSK 30G needle, which tend to have a larger bore, which allows me to inject the product with ease. Let's take a look at this study that it was done with Restylane Silk. And you can see that when you compare it with Restylane Silk, most of the patients thought that the lips shape and the features of them and value were much improved or very much improved when compared with the competitor. And then over here, you can see that when you use this product, you actually use less volume. And again, these are the clinical trial highlights. Most of the patients and subjects and injectors thought that the patients got a much more improved look of the lips. Most of there were fewer adverse reactions in terms of inflammation post-injections, and we require less volume when using this product. So again, if you are not injecting patients that are older because you feel that you do not have the right product, if this product is available to you in your area, give it a try. Thank you very much.
Thank you so much, Shino. And I believe next is Chaitra.
Hi, Julie. Hi, everybody. Good evening. From here, I guess it's good morning to you guys. All right, I've lost my voice a bit, so forgive me, and I'll just get my presentation started.
Chaitra, you are muted at this moment, and thanks for taking the time. I know you've been running helter-skelter to try and make it for this meeting. Thank you very much. We appreciate you.
Just give me a moment. I'm just getting it started. Should be about now.
Great, thank you. We do have a backup plan, but let's hope your presentation starts.
There. I think it's started.
Chaitra, you may want to not screen share, start the PowerPoint, and then screen share the open window.
Okay. Do you want to tell me what's going on? Sorry.
You stop the screen share, go ahead and open up the PowerPoint in another window, and then screen share at that point.
Okay. You want me to open the PowerPoint and then start the
Screen share.
Gotcha.
That's right, yes, yeah.
Gotcha.
And our backup plan is we have a video of Dr. Anand presenting, but we'd rather hear it live. So we're going to all bear with her for just a moment. And we do appreciate you have so much going on and you made it happen. So let's hope the presentation works.
Yes,
Yeah,
I'm
let's-
sorry, your voice sounds a little hoarse, but we're so excited you could join live.
All right. I think this should be okay. So let me try this. Okay, there we go. Can you see it now?
Yes. Yes, we can see it
Alright.
now. You can just
All
go
right.
on here. Fantastic. Let's go. Chaitra, you're on mute. Yeah. We can see the slides, but we can't really hear you, Chaitra.
Ma'am, the audio has not been selected. Could you please reshare?
We may have to go ahead and switch to her prepared video. And of course, she's here for question and answers.
Right. Can you guys not see the video I'm presenting?
Oh, now we can hear you. Yeah, go
Yeah,
ahead.
we
and
can
present.
hear you. Please go ahead.
1 second. Okay, just when I play the video, this injection video is pre-recorded. So just see if it's playing, please.
But I think you've not selected the audio, so you'll have to speak
go ahead and
because
speak
we
now.
can't hear the audio. You can speak now.
How do you select the audio?
You'll have to select it during the resharing. When you're resharing, if you can stop the share and then go to the share screen again, there'll be a small checkbox which will allow you to start the sound on the video as well at the bottom of the sharing screen.
Gotcha. Got it. Share sound and optimize for video clips. Got it.
Yeah.
So then I'll restart it. Sorry, guys.
No, that's
Thank
fine.
you. Let me just get that organized then. Okay, that should be good. Okay, it's giving me some kind of
Yeah. We can see the presentation now.
okay. Let me see if the audio works.
Hi, I have no conflict
Yes.
for today's lecture. Let's start off by me showing you a video of how I do the procedure.
So we're gonna do the lips now. If you look at her lips, she's got beautiful line. The edges have already pronounced. So I don't really want to do the borders, but I want to do the volume. Okay, so this is what I would like to do for her lips. So I'd like to give it a little bit of a volume so it opens up like this on both sides and maintain that tubercle. So to do that, first I'm going to mark where her GK points are. Okay, and we have to do the filtering to just define that area a bit. And what I'm going to do is I'm going to inject her from the vermilion to the junction of the wet and the dry in the mid plane here. If I inject along here, I'll be able to achieve volume in her lip area because I want to do it in the mid plane. That's the safest area, and you want to be superficial to mid superficial. So you want to be on the surface, but you don't want to be very superficial either. And I definitely want to define the tubercles here, the lateral tubercles, which would be right under the GK points, her medial tubercle, and a little bit into the philtrum. This is the area we're going to work on. Okay, first, let's do the medial tubercles so that we can define these 2 points. Okay, so 2 points, pinch this area, give a small little pricky there, and a micro aliquot for this. There we go. Once done, you can then climb up here superficially. You can see me going, and only 3/4 of the way. You want to be about 60 to 75% of the way to define that philtral column. That's it. That's what you want to do. You don't want to define it all the way till the end because then it'll look too defined. So if you can see here, she's got that tubercle and a nice little lift here. Same on the other side. Just turn towards me. Pinch between your hand, a small little prick, a micro aliquot right there, and then go in medially right there. You can see me, I'm up till here, and while injecting retrograde and anterograde, withdraw and back. So if you can see now, you'll see that she's got 2 GK points and she's got a nice definition of that philtral column right there. I also want to define the middle, the Cupid's bow, a little bit more. The way to do that is from this point till here and here, because the rest of her lip is beautifully defined, but this part is not. So, you're gonna feel a small sting here, sorry. And you want to be on the vermilion border while doing this. And you can see my needle, it's an anterograde, and I'm till there and out. That's it. You can see that beautiful definition to the Cupid's bow on this side. I'm going to do the same on the other side. Again, at the peak, small pricky in, you can see, and it's on the border, and slight definition. There we go. That gives it a beautiful, nice Cupid's bow and defines that upper lip for us beautifully. Now to give her the volumes in the corner. Okay, you want to invert the lip here, press this down, and you never want to go right from the corner, just a few millimeters in, maybe 4, 5, small prick in the middle. And can you see how my needle is? No puckering, but I can still feel my needle. This is the plane of injection. And I'm doing anterograde and posterograde for the volume. Right here, in the middle. There we go. Beautiful. Now you can see how that lip has everted and there is volume compared to the left. When you see the right, just say ah for me please. Just slowly, just gently feel it. Make sure it's nice and even. Okay, relax. And you can see that beautiful eversion. We're going to do the same on the other side. That's it. Invert. You can do it this way or you can invert it this way, whichever suits your position. I'm going to do it this and this. It's better for my hand balance. So we got this going upwards and here. And I can start from here, mid between the wet and the dry border and the vermilion. And here I am. You can see that volume going in. Gentle injections. There we go. And another point. And just very comfortable because you're doing slow injections. And if you do slow antero and posterograde or retrograde, you'll get a nice numbing. So There we go. Let's have a look. Can you say ah for me? Ah, yeah. Just smooth it down, get a feel how it is feeling. Feeling good. All right, just relax for us. And you can see how the eversion has happened on both sides, and it's looking beautiful. Now, the lower lips are lined, but we would like to get a little bit of tubercle going here for this to get that. And we also want to highlight that medial tubercle a little bit. So we'll just give her a wee bit of product into the medial tubercle. A small prick, you'll feel a little shot. So it's just right here at the cupid's bow. A small pinch, that's it. And a little bit of a product right there, gently. And that gives it that nice little middle tubercle. Now to work on the lower tubercles. So the lower tubercle, if you see the GK point, it's right underneath. You can do them individually, one here and one here, or you can go from this all the way across. I prefer to go across. Now, just to balance this, the tubercles. You're gonna feel a small squirty here. It's in here, that's it. So I'm right there. I'm giving her a small little blob for that tubercle, and very slowly, it's a slow injection. Then I'm going to go across, and I'm at the other tubercle. I'm going to give her a little bit more there, just to give it a little accentuation. Very slow and gentle. And out. So with one point, I'm able to do both the tubercles. So let's just define this a bit. You can see this. All right, let's have a look. Smile, relax. Smile again, relax. All right, say ah for us. Just feel the entirety of the lips. Make sure that nothing feels blobby. And these are very smooth products, so they'll smoothen themselves completely. So we're going to do the lips now.
Okay.
So when we look at the lips, what are we looking for? Well, full radiant lips suggest beauty, youth, fertility, sensuality. With an upward slant, are they hydrated? And we're also, of course, looking at the periocular areas for lines or bar coding. Brown. The ideal proportion of the upper lip is 3.5 millimeters anterior to a line that's projecting from the lower lip. And this should ideally be 2.5 millimeters anterior to this line. And the height of the ratio between the upper and lower lip is generally 1:1.6. And so what we're trying to do is look at all of these proportions when we're creating that ideal lip proportion. It's also important to look at the musculature and to understand exactly where the mucosal area is, where the musculature is, which is the orbicularis oris muscle, and the relationship of the lip shores. So when I do my lips, I always classify, is it correction for thin lips, enhancement for normal lips, or is it a rejuvenation for older lips? Then I note the points, the shape and volume, the filtral columns, the balance of the upper and lower, the relationship of the nose, the chin, and the facial proportions to the lip. Of course, the texture, definition, and movement. So when I look at a young lip, what I'm trying to do is I'm trying to just enhance it. I don't want to lose the natural vibrancy of a young lip. It has to be full, luscious. And this is exactly what I'm trying to achieve. one of the techniques I use is where I work along the vermilion border, and I initiate this from the mucosal side by inserting the needle laterally at a 45-degree angle and direct it towards the center. And I tend to do antero and retrograde injections, and I maintain a very gradual injection rate, and I stretch the lip slightly to give me a better holding position. I also place injections into the lip, into the middle of the lip, to give it volume. And these techniques have stood me well over time. And of course, into the lower tubercles of the lower lip, and this is how upon the lips. And there you go, 4 weeks. And when I look at the fullness measurement in the profiloplasty, you'll see that enter projection by 2 millimeters of upper to lower lip. And with older lip, it's typically a correction or is it an enhancement? Most times it's a correction and rejuvenation of the older lips, and I tend to work more in the oral commissures because they tend to downturn. At this time, it's critical to support the cell and not just the lips. I also look at the combination technique when I'm doing the entire lip. So if you look here, there's perioral lines or bar coding. So I'm working with skin boosters, which are non-reticulated hyaluronic acid. I'm working with fillers and neuromodulators to achieve a synchronous result across the lip. So this is my technique right here. So this is the skin booster along the perioral region, and then it is the neuromodulator injection, and again a profiloplasty, and also the frontal view, just one serum. So in conclusion, I'd like to say, know your anatomy and respect it. Assess the lips at rest and in motion. Think it's not just a filler, it is a combination therapy. Assess the lip and its surrounding area. And now, with the advent of laser technology, sometimes I combine laser to give me a better surface around the lip also. Because if your lip is hydrated but the texture around it is not good, it's not satisfactory. Thank you for your attention, and if you have any doubts or questions, feel free to DM me on my Instagram account.
Right,
Right.
Chitra,
Thank you for your attention.
thank you so much for your lovely talk. And I believe next we have Dr. Michael Gold. We'll do questions at the end, correct?
That's right. Yep. Thank you.
Hi, everybody. This is Dr. Michael Gold, and I'm coming to you via recording today for the Global Cosmetic Surgery Aesthetics Masterclass. I will be there for the question and answer via my phone. I'm on a holiday and on the road, and I couldn't be there to give this talk in person, but still cannot thank Tanuj and Debraj for inviting me to be part of this. Incredible group of physicians and incredible docs that you all have put together. And congratulations to everybody. And yeah, soon, someday we'll do this in person, so we can all be together. But I'll be around for any questions at the end. So again, my name is Michael Gold, and this is perioral and lip laser modalities. These are my academic appointments. Of note to me is that I am the editor-in-chief of the Journal of Cosmetic Dermatology and Dermatologic Reviews. Both are Wiley journals, and we always welcome articles. And thanks, Debraj. You're very good at doing that, so we appreciate it. I do speak on behalf of just about every laser company. For purposes of this talk, I'm going to be showing mainly the Cyton laser devices that we use the most in my practice, and others do as well, for the perioral and lip wrinkles and lines, and how we do that and what it is. So when we talk about this, I think we all know that consumers are always worried about skin texture, lines and wrinkles around the eyes, around the mouth, and these things haven't changed. And I think we've all seen during the last 15 or 16 months, from being on as many of these Zoom calls as we've all been on, that people are interested in removing them. They've had more time. They still have more time. They're interested in procedures. A little bit of downtime is okay for most of the patients that we've been treating. But the demand is there. The demand has continued to grow, and this is still a very important part of what we do on a daily basis. I want to thank Joel Cohen and Jason Posner at the beginning for allowing me to have some of their slides for this. And I think we can agree with this report that was done in 2015 by Joel Cohen, that perioral rejuvenation with ablative erbium resurfacing, is one of the best treatments that we have. Full field erbium resurfacing is safe, it's efficacious, and it merits consideration in our patients that are really bothered by these etched lines and wrinkles and how we do that. So again, here's a patient of Dr. Cohen's. You see pre-treatment 1 week post, 2 weeks post, just one treatment there. And on the bottom right, 1 month post, two treatments. There's not much else that we do that are going to give us these kind of results. So I think this is something that we need to consider in our patients. And again, Joel wrote about this in 2021, now 2 months ago. The pendulum should swing back, combination full feed erbium and fractional ablative lasers for photo damage. Again, looking at this and knowing that this is something that we can do for our patients, and we can do combination therapies as well. So this is Botox, one full field erbium treatment, along with some dermal fillers. You see here the Botox, the botulinum toxin was 6 units was given 1 week prior to the resurfacing. There were 3 passes with the erbium laser and hyaluronic acid fillers. So it gives you this complete rejuvenation effect at 3 months. And again, I think nobody would argue that this is the kind of results we're looking for. So again, the Cyton system, there's lots of different Cyton systems out there. The ones that have erbium still are one of my favorite systems out there. You have a single spot handpiece, a zoom scanning handpiece, and this profractional handpiece. You get with CO2 a zone of tissue coagulation seen adjacent to this defect created by the laser, but with the erbium, you don't have that. And that's sort of what gives the beneficial effects of this. The combination of erbium and dual pulse technology yields independent control of ablation and coagulation. And so we can adjust and treat as needed, and look for what we got. So the history of resurfacing obviously covers a gamut of different devices, still most of which are in play today. May not do as much in your clinics with CO2 full field, but CO2 fractional for sure. Erbium full field, especially around the eyes and mouth. Again, we have ablative those. We have different systems, including the hybrid systems, the 1927 and so forth. So again, when you look at something, that gives us the test of time, erbium resurfacing here gives this incredible 6-year result. So one of the things that we need to always consider is, how much downtime can somebody give us? So if it's today, they have no downtime availability, maybe an intense pulse light, broadband light, just to help with the skin. If they can give you a day or two, you might want to combine 1927 and a broadband light or IPL. 3 to 5 days, again, halo or hybrid systems with either pulse light or one of the erbium things. And then, if they can give you a week or 10 days, that's the ultimate full field effect. And again, with the contour system and the nano laser peels that we have, the micro laser peels, we can get this. So when we talk about full field ablation with the Cyton system, we're really talking about contour TRL. The laser scans an overlapping serpentine pattern covering 100% of the targeted area. The depth of ablation is variable, but you can go up to 200 microns per scan. You can replicate the outcomes of other resurfacing technologies from traditional erbium to YSGG to CO2 with pre-programmed coagulation. So again, this is a micro laser peel. This is 5 months post-treatment. Again, there's not a lot of perioral lines here, but again, good result. But when you start talking about deep resurfacing, again, look at the etched lines for all of these patients. And again, these are one treatment, 3 to 5 months in many cases. This is 6 weeks after one treatment. Not anything else is going to do this to give you this long-lasting thing. And again, this is the 6-year result. This is 9 months post one treatment. Again, with this contour, this patient also had a facelift. This is again really severe photo damage, lots of lines and wrinkles. Just 1 month post one treatment, you see the improvement. And again, look at the lip area. Those etched lines are gone at that. And again, this is 6 months here. Those etched lines disappear. So again, when you do this full field erbium treatment, these are predictable results. Now, this patient has lines that are really hard to treat. And this is just one treatment here. Again, you see this is 50% overlap, 150 micron ablation, 2 passes with an additional pass over those really deep lines. And I think that that's an outstanding result. Another patient here, 2 months after one treatment, you see the improvement in the lines. Another treatment here, 6 months. This is 1 year later. And then we get into profractional, which is their fractionated erbium. The laser scans a pattern drilling individual holes that can be set between 5 and 22% density of the surface area treated. The depths can go anywhere from 25 microns to 1.5 millimeters. And again, you can combine this with other things such as the 1064 laser that they have for hair and vascular, broadband light or intense pulse light for pigment, rosacea, skin rejuvenation, and you can do halo as well. So again, when you start looking at the combination treatments, that's where we're starting to see some significant, even better changes than just by doing the contour by itself. Again, you see here these etched lines disappear. The skin around it looks much better. Again, using combination, again, with this kind of patient where they have pigment, the broadband light helps with that. And you see the improvement. And this is just 4 weeks later. Here we are 5 weeks post 2 treatments. Again, that massive improvement in the etched lines and so forth and so on. So again, all of these kind of results with the combination treatments gives us an even better result. So start thinking of how you can do this combination wise in your patients that need these kind of treatments. So again, I think this is really impressive. These kind of results are not going to be gotten with some traditional, just by taking a non-ablative fractional device by itself. This is deep contouring with erbium lasers. And again, you can do this by the contour, or you can do it through combination therapies with broadband light or with profractional or together to give you this. And then these are just some of Dr. Posner's patients that you see here in perioral resurfacing. And what's impressive is that you get these long-lasting results as an effect of this kind of treatment. So 4 months, 2 years. Here's another patient, 1 year, another patient, 1 year, 1 year post, 1 year post, 3 years after the treatment, again, with some significant results. 1 year, another 1 year result, again, 6 years, 1 year, 2 years of the same patient, 6 years of that same patient, and 9 years post one treatment. And so again, nothing does this. It's the ultimate in resurfacing, especially around the mouth. This is what we do. This is what we recommend. And I want to thank you for letting me share some of my friends' stuff. But again, this is what we do in our clinic as well. And I'll be around for the question and answer period. Thank you very much.
All right. Thank you so much, Michael. Fabulous presentation. I love the erbium laser. I have one. And thanks for sharing Jason Posner's slides. He's a great friend who came to visit me about a month ago. And so now we'll go ahead and move on to our next talk with Dr. Supra Vadera.
Yeah,
Ms.
thank you so
Capella?
much. Yeah, thank you so much. Um, Hello, everyone. I'm Dr. Sapna Vadera. I'm a craniomaxillofacial and a facial plastic surgeon based in Mumbai, India. And my topic today for this conference of global cosmetic surgery is the interplay between the lips, nose, and the teeth. Before we begin, I would like to briefly talk about a beautiful smile. So, what exactly are the criteria for the beautiful smile? It begins with the vertical dimension where the teeth, the incisors, the cuspids, the premolars, etc., should be clearly visible in their vertical height. The gingival display should be approximately 2 mm. The upper lip cant should be parallel to the maxillary plane. The lower lip cant should also be parallel to the cervical part of the maxillary teeth, which are the incisors, the lateral incisors, cuspids, and the premolars. And the vertical midline should match. These are the basic criteria which gives a beautiful smile. As my topic is the interplay between the lips, nose, and the teeth, understanding the smile becomes very crucial. As I said, the normal ideal gingival display should be approximately 2 mm. When we talk about the rickets plane, which is the distance of the nose tip, which is the plane formed by the nose tip to the chin prominence, the upper lip distance from the rickets plane should be 4 mm and the lower lip distance from the ricket plane should be 2 mm. Discussing the important angles, the nasofrontal angle is ideally 115 to 130 degrees. The nasolabial angle is approximately 90 to 110 degrees. The nasofacial angle is 36 degrees. The nose, lip, chin plane is the plane which forms between the nose, the upper lip line, and the chin. Chin should be 3 mm behind this line. Moving on towards the aging, we did a study about the aging of an Indian face because in literature there are multiple studies talking about the Caucasian face, but talking about the Asian Indian face, it's very less. So we did a photographic study where which was published in the Journal of Plastics and Reconstructive Surgery, where we talked about the aging face, which is usually oval when a person is young and becomes broader from the lower half of the face as the person grows older and older. So this is about the aging of the Indian face. Moving on, how the aging affects the lip, the jaw, and the teeth. What is the interplay between these three structures, which is the topic of my talk today. Moving on, the effects of aging on these structure. So ideally, the youthful lip is usually, it forms a cupid, M-shaped cupid over the upper lip line. And there is a faint, less distant cupid between the upper lip and the lower lip line, which is a faint M which is visible. And with aging, these features usually disappear. Everything starts to sag down, and the lips become more sunken. The fleshy part and the chubbiness of the lips decreases. The bulk of the lips decreases with age. Similarly, the nose width to lip length, which is in the golden proportion, also there is a disfigurement of this ratio. And while restoring the face again towards the anti-aging, restoring this aspect and this ratio is very important. So as I said, that with aging, there is the drooping of the corner of mouth. There are fine lines, there is loss of lip support, there is loss of support of the lower third of the face, which ultimately leads to all the, which in combination with aging leads to all the disruptment of the facial proportions. When we talk about the effect of bone, the alveolar bone, as we know that teeth plays a very important regulation in controlling and in tuning the work of the alveolar bone. So with aging, when there is a teeth loss significantly over the period of time, because the teeth are the important structure which sends the signal leading to the churning of the alveolar bone, the forming of the alveolar bone, that is disrupted. And over the period of time, the alveolar bone it would not just lose the length and the width, but it starts getting depleted in the volume, as a result of which the ideal golden proportion of the face is usually disrupted. The lower third of the face goes on reducing, and ultimately there is it has been noticed, and it's in literature that there is a 25% decrease in the width of the bone during the first year and after tooth loss, and over 4 decrease in the height over the next coming years. Now, how we take all this and what would be the interplay of all these structures while doing the anti-aging treatment, that is what I'll be discussing now. So the interplay of nose and lips would be that in the study by Perkins, which was for the first time that he described that a predictable correlation was seen of nearly 0.05 of upper lip length for 1 degree of the tip rotation, which was noted. So with every 1 degree of the tip rotation, there was an increase in 0.05 of upper lip length. So when the columnar strut graft was done, with every 1 degree change in the nasolabial angle, the lip length was changed by 0.04 With the caudal septal extension graft, with every 1 degree change, there was a lip length change of 0.05 So here in the pictures, you can see that with the tip rotation, the tip was rotated upwards, which led to the increase in the upper lip length. There was a beautiful display of the upper lip line, which was seen on this view as well. This is also one case where after the tip rotation, there has been an increase in the upper lip length. Now, not just the nasal tip, but also the mid-face balance and support also affects the lip. There is an interplay of the bone bulk, the tissue bulk, which affects the lip line, the lip symmetry, and vice versa. So this particular lady came to us with a sagging lower face, sagging mid face, and as a result of which the lip show was blocking, the lip show was being blocked, lip display, upper lip line was being shadowed, was being masked. So we did the fillers in the pyriform fossa for this patient, and by doing the fillers in this part of the face, and in the cheek area, then ultimately what happened was the face was lifted up and the lip show automatically increased. So the interplay of moving the face up and increasing the lip length was very important and crucial. Moving on to the effect of maxillary bone. So in this particular patient, the patient had a visible deficiency of the maxillary bone. At the same time, his mandibular jaw was prognathic. So a combination of bijaw surgery was done. Now you can see in the first picture, the before picture, where decrease in the bulk of the maxillary, retruded maxillary bone, and you can see the position of the lower lip, how stretched the lower lip was, how everted the lower lip was, and how the symmetry of the face, the balance of the face was re-achieved by beautifully doing a bijaw surgery for the patient. Similar for this patient, where the maxilla was anteriorly placed, the maxilla was placed forward, and the surgery was done for the retrusion, the retracting the maxilla, and as a result of which the strain on the middle, below the nose was reduced. This part was reduced, ultimately giving the relaxed, the balanced look to the face. Same in this patient, as we can see, the middle third of the face is retruded. There is a prognathic mandible. There is the eversion of lip, too much strain on the lower lip, and how the symmetry has been achieved by remodeling and replacing the bones after a bijaw surgery. Now, not just bone, but teeth have a role to play. As we know, in this patient, the teeth were not in the golden ratio, and see the position of the lower lip. See how uncomfortable and how poorly balanced the lower lip is, and how the symmetry and balance was achieved by just putting the teeth in the proper shape. The absence of teeth again leads to the drooping of the upper lip, and how the symmetry and the balance and the lip support was achieved after giving the patient dentures. Now see in this line, the rickets line has the distance of the upper lip and lower lip from the rickets line has been achieved after giving the patient a denture. This is one of my favorite pick from the particular article quoted below, where see how the golden ratio has beautifully been achieved for this patient after a full mouth rehabilitation was done. So this picture clearly depicts the role of teeth in the facial proportion, in the facial balance, in giving the symmetry, the support to the lip, the lower half of the face, the mandible, and the overall balance to the face, putting the face back again in the golden ratio. Now, considering that dentures would support and dentures would give this support to the face is not right, because if it's not the only solution, and denture would give somehow this sort of the look to the patient, not supporting the lower half, not supporting the middle half properly, because it's just replacing the teeth, not doing nothing for the support of bone which is being resorbed every day. Therefore, implant should be ideally placed so that the facial height over the years is maintained, like in this particular patient. So to end with, I would like to say that it's not just about rejuvenation, it's also about retaining what is there. It's about relaxing, it's about redistributing the things, it's about refilling, it's about redaping, and it's about resurfacing. So if a particular person can look as young at the age of 65 as they not were in the age of 25, then it's definitely lies in the hands of the surgeon that how their patient should look. With this, I would like to end my talk. Before ending, I would like to say that at our institute in India, the aesthetic clinics we have an International Academy of Facial Cosmetic Surgery, where we take fellowship courses in facial aesthetics under the mentorship of Dr. Debraj, Dr. Rinki, and myself, Dr. Sapna Vadera. And this fellowship is accredited by the International Indian Society of Facial Plastics and Reconstructive Surgery. And the next batch starts from 20th August 2011. So you can get back to me anywhere on these login details, this social media details. And thank you so much. Thank you.
All right. Thank you so much for these absolutely amazing talks. You want to speak to Tanuj, or should I go ahead?
Well,
Go ahead, Julie.
Yeah. Oh, please go ahead, Dr. Achima.
Yeah, we can, be together. And thank you all faculties. This is amazing, fantastic talk. I love all your talks. It's beautiful, beautiful injection technique also, Chaitra. I love your talk. Yeah. So actually we have some questions. We have questions from Dr. Manush Labai Kanus. He asking about in non-surgical lip lift, is there any advantages with facial exercise or massage? What do you think? Anybody? Anyone?
Okay. Personally, I don't think facial exercises are going to help us lift our lips up or get any kind of aversion. In fact, I think if we overuse our muscles around that area, we're going to get ourselves wrinkles a little faster. But the muscle sheet in our face is so thin. There's no toning that we can do with facial exercises. This is my take on it.
Well, anyone have a different opinion? Well,
I have to agree with Dr. Chitra. If you just look what we have able to achieve with neurotoxins and relaxing the muscles, so I think it's counterproductive to do all these exercises. The more you move, the more we're gonna age. An example of that is that we age faster, and it's a lot harder to treat areas of movement with the passing of time. So I think all these exercises, the only thing I can do is to contribute to an accelerated aging appearance of the area.
I actually also agree. Can I comment?
Yeah, of course.
I'm moderate, but can I comment? So I actually agree that maybe it wouldn't help, because that actually there's so many factors that lead to the aging appearance that we see. So facial exercise might not be able to, or even massage might not even be able to help this. Julie, what did you think?
Oh, I agree. I think it's a very wishful thinking if anyone thinks that exercises are going to truly be able to lift the lip. I think one form of exercise is actually using a little bit of neurotoxin to weaken certain muscles so the other muscles can take over, to help avert the lip. That's probably about as good as you're going to get with the exercise for new muscles.
Yeah. Alrighty. So we go to the second questions from Dr. Nielsen. His question is, he would like us to comment on the injectors, actually the inject lips without aspiration. So he would like to have our comments on aspirations during injections on the lips. Chetra, Julie, Chino, and
I usually don't aspirate when I'm doing lips, and I'll tell you my reason. I remember when I did my lecture, we are really very close to those superior inferior labial arteries. We are just very, very close. But for me to make it safer, we all do things to make it safer. None of us have X-ray vision, so we do the best we can to know the anatomy, trying to know variants. But I like to get my product into insulin BD syringes. And I tell you why I like it, because when I do this, I feel like now I have this tactile ability to tell what it feels like to be in the submucosal space. And I can check myself with it. I'm closer to the action because the nature of those tiny small syringes. When I use the provided syringe needle, I feel so far removed from it that that I feel like I sometimes, at the beginning, maybe injecting too deep, too superficial. But I mean, I see people that they do aspirate in this area. But again, if you know that you're in the submucosal space, most likely, and you check yourself, you tent the needle and you see that you're not too deep and you're not too superficial, you should be more or less, because nothing's 100% safe.
Yeah.
I
And
think that would also come with experience. If a person is very new into the practice, for the beginners, we would definitely recommend to aspirate and then move ahead. But as the experience comes, it would automatically flow into the place. There's so both the school of thoughts apply for that.
And I think another common question that goes along with that is also, do you use needles or cannulas? And every audience I've ever spoken to says it's a blend. The average is always a blend of both. And Chino and I, we just talked about that in Dallas with a group 2 weeks ago when I was speaking there. And our group, same thing, a blend.
Yeah.
Can I comment real quick?
Please, Michael.
Sure.
Hey, so I always aspirate, and I'm very comfortable not aspirating, but having done one on stage where not on the lips, but in the face, when I had blood come back.
I was with you that day, remember?
In front of 1,000 people, I aspirate every time now, and that changed my thought process. And again, I don't think I have to anymore because, like Shino said, we're really comfortable where we are. But out there, if you're injecting, and as we just heard, if you're not an expert injector, always aspirate.
Yeah.
If you aspirate the lips, but I want to know, do you really aspirate the lips, Michael, every time you inject now?
Every time I inject.
For the lips.
Yep. It's just more paranoia than anything else. But again, I just feel much more comfortable when I start. I just always pull back on that syringe, and then I know where I am usually, and every time, and then I just inject.
Dr. Dongmei, sorry, Chaitra, sorry. Did I cut you off by any chance?
Yes, you did.
Please go ahead.
So
I'm so sorry.
That's all right. I was just saying that, I don't aspirate when I'm doing the lip itself. I just make sure that I'm really superficial, and I use the thinnest needle possible, like Chino does, when I'm doing the lips. Only reason being that with the lips, it's so fine, and we're so superficial in our injections. I find that by the time I aspirate and go back, even if I do a single hand aspiration, the plane shifts for me. So that's it. But that's one area that I still am okay saying that, yes, I've had an vascular event. And, so I do tell my patients, and I take them through what are the possibilities always. And I keep a watch. And we were able to manage a vascular event around the lips with highlights immediately, and that was fine. So it's just about that. So that's my personal view. But every other area of the face, aspiration. I'm done.
Could I request Dr. Dongmei to ask a question as well? Dr. Dongmei, you had a couple of questions which you put up in the chat box.
Okay, thank you. Even I don't do the lip and the nose injection or the rhinoplasty. I only do the oculoplasty but it's still very interesting. Wonderful talk. When in injection, I have seen some of the case when do the nose injection, but cause the blindness. I'm wondering, do you have the experience when you do the lip injection and it cause the blindness?
The network is a little patchy, so I'll take the opportunity to repeat what Dr. Dongmei says. I think she's asking if any of us have had a blindness event or a vascular event post injecting either the lips or the nose. The faculty, please.
I haven't had any blindness events. I've had one vascular event from a lip injection, but you know, I train my patient on what to look out for, and we always have a system in our clinic where we keep a watch for them, and then we give them a post-op call after like 2 hours to just check how they're doing. And the end of the day, we've done the procedure earlier on just to make sure before we close clinic, and just ask them how they're feeling. And this particular patient, actually, she was in the clinic waiting for her billing, and she just felt a little funny on her upper lip. That's how it happened. And I mean, the anesthetic was still there, but she just felt that it just felt funny. That's what she said. So immediately we examined her, and I could start seeing a slow blanching starting to come up. And what I do is I always go an inch away and then highlight backwards when I highlight. And that's what we did, and it reversed right away. And so I have the whole picture series. So that was the only event I had from the lip injection. I've not had any adverse events so far.
Julie, Shino, Achima, Michael, your thoughts?
Okay, I see. Thank you.
I have injected intravascular one time at the beginning of my career, and it was similar to what Dr. Chitra was saying, similar event and the way I handle it. But I remember going to the class of Arthur Swift and Sebastian Cotefona, and they show in one of the PowerPoint slides, a slide I'm pretty sure many of you have seen, on a lot of areas on the face that have led to blindness. So it is possible, but unlikely, right? These are really rare events. I have yet seen or heard of someone going blind yet, like any of my colleagues around the world on this area, but it has been reported.
I think that, you know, I'm an oculoplastic surgeon, so I do follow, you know, cases of blindness. And of course, Katie Blazeney's paper is so important because she reviewed the world literature. I haven't heard of a case of just pure lip, but it's important to remember that 42 to 43% of patients lower circulation will connect to the orbit. Not everybody has an angular artery that connects to the dorsonasal. So if an event is going to happen around the lips, it's probably more likely if someone's injecting the melolabial oral commissure.
Yeah,
it's always possible. We should always beware and always use small alloplats and always keep the needle moving.
Julie, I had a question for you actually, because you're oculofacial plastics, and there was this interesting paper which was published by Dr. Milan Naik from India just last month. And what it spoke about was that the retrobulbar hyaluronidase is something which doesn't really work, because they had an in vitro model which showcased that the hyaluronidase does not actually reach the central retinal artery, and therefore it is just a placebo treatment. It doesn't really work in dissolving any filler which has flown into the ophthalmic artery and then the central retinal artery. So what do you think about that?
Yeah, I don't think the hyaluronidase is going to pass the dura around the optic nerve to get a central retinal artery occlusion. But what we wonder if it may help is a lot of the cases of blindness are partial, and they're actually in the choroidal circulation, and it may be able to penetrate those little choroidal arteries, because there's a ring of very teeny tiny little arteries that feed the choroid, which feeds the retina around the optic nerve. And if someone has that form of blindness, there is a chance you could improve their vision. But there was a study with 4 rabbits where they induced blindness with filler in the central retinal artery and then injected hyaluronidase, and they recovered vision in 1 out of the 4 rabbits. So bottom line is we don't know. Probably doesn't work. It's a good thing to have in your armamentarium.
Sure.
Yeah.
Achima, any questions, or should we declare the session closed?
Well, what's the time?
We
are just
actually are probably,
Questions?
we probably need to conclude, yeah, because we're about 10 minutes behind. But Julie, any final comments for session one?
No, this is an amazing session between going from fillers to devices to surgery. And I think we covered a broad breadth. And this is all really just a segue. Dr. Videra, your talk is an amazing segue into the next section. Really excited to hear Ben Talley's talk. I do surgical lip lifts, and he's written the best paper with over 800 cases of surgical lip lifts. And so please take it away. The next session will be amazing.
Thank you, Julie.
So I'd like to introduce Jocelyn Cohn, who's an oculofacial plastic surgeon trained at UCLA, who is in Chile. She's one of the leading minds in South America, in leadership positions in South America. Thank you, Jocelyn.
Well, thank you. All of this has been a great experience and fantastic presentations. So I'm thrilled to chair this session today because, you know, beyond fillers, there's a huge, huge and unexplored world for surgery and lip rejuvenation. Here in Latin America is all, you know, kisses and curves and a lot of sensuality. So lips have always been key in our practice. For pandemia has its big revolution for all of us worldwide. So patients are not afraid of lips anymore, but there's a lot of new trends and they go viral, and the cosmetic industry has in the last year come up with new products and technology, and physicians come up with new techniques, and well, let's hopefully pursue, you know, more natural and personalized lip aesthetics. So I will be honored now to welcome Dr. Ben Talley. He needs no introduction. He's a world-renowned facial plastics and reconstructive surgeon. He practices in Beverly Hills, and he has lectured and taught doctors, plastic surgeons all around the world. He has contributed greatly through social media. He's big and talented, also in different aspects on cosmetic surgery. So we're all here eager to learn more about his famous modifications in lift surgery. So please start sharing your screen now.
Yes, thank you, Jocelyn. So what I wanted to share today, which I think is kind of cool, is not the technique necessarily for deep plane lip lifting, which is what I do, but the design elements. And I think this will help people understand like what contributes to a beautiful, sexy, youthful lip. And what I'm showing hasn't really been described before in the literature. So it's pretty helpful whether you're doing injections or not, or surgery. The other element that I think will help, just as in deep plane facelifting, is that when you teach these techniques, people learn the anatomy better. So I've seen through programs that don't teach deep plane facelifting and they just teach the mass plication techniques, the surgeons graduate and go on in their careers without really understanding the anatomy of the face. They never saw the different planes and the different tissue components that exist in there. And with the lip, it's the same thing. If you haven't been in there surgically, it's really hard to understand really what makes up the lip. And I'll show those kind of things as I go on. So I advise generally against all the creative types of lip lifts that have come about ever since the first one was described in 1971. In an international congress, Cardoso and Spurley did describe the subnasal lip lift in the most logical way that would exist for the next like 50 years. Everybody else came and just like in the world of facelifting, rather than getting rid of the tension and the things that were leading to the problems with scarring, they would just try to hide them. So facelifting, that's what doctors do, and they go and put incisions up in the hairline and do things like that to hide scarring rather than getting rid of scarring from its source. And that's what you see in lip lifting. They would come and do the Italian lip lift technique, which is like limited little incisions, or put the incisions inside the nose. And really those all cause irreversible scarring that can't be fixed. So it's best to stick to the subnasal lip lift, and you can just perform a deep plane. So this is the paper that I published that Julie was referring to so nicely. And it's a very basic paper for surgical technique, so it's easy to replicate. And the next paper I've written, I wrote it like a year ago, and I just haven't published it yet, unfortunately. It'll be released soon, but this is the basics. Is we're reviewing it's 2,200 patients, and looking at things that led to revision and reasons for patients coming in the first place to have these surgeries. And I like to just teach the aesthetic taste rather than saying, okay, these are the guidelines and proportions and definite numbers that you have to follow, because it's a mistake to think that the lip should be 11 to 16 millimeters tall. That doesn't make any sense. You know, people have different size faces. So there's really no range that is aesthetically pleasing. It's a balance throughout the whole face. The thing that the dentists have realized for a long time is that incisive display portrays youth and sexuality, sensuality. So you communicate with the eyes and the mouth, and you want both to have that brightness. So bright white eyes and teeth showing at the same time portray some youth and sensuality, sexuality. The other thing that I've noticed is that patients really are seeking exposure of vermilion from medial to lateral all the way throughout. And you see that with patients with buried lips laterally. They're always trying to find ways to lift it. You can't lift it with fillers. It's not possible. So doctors chase it by adding more and more there and just bulking it, and it gets heavier and worse. So the corner lifts are a nice thing to do that I'll talk about. And the other is the vermilion border itself at the wet dry border. The sexy, beautiful lip, and this is something that's not trendy. It is just a sexy, beautiful lip in general. It's a smooth internal arc. So yes, we have an M shape at the top, but you don't want to parallel that on the wet dry border. And that a lot of doctors have been talking about, which is nice, because I do see out of some countries, people try to make an M-shaped lip on the internal border of the vermilion, and it looks disgusting. It looks evil. It does not look happy or nice. So just those general shapes, it's good to understand that, you know, what looks nice and what doesn't. And I'll go over the slopes from lateral as well. It's nice to have just a slope that goes out rather than something that goes too far. So what we consider overall is balance of the lip to the rest of the face. And the other part is skeletal to soft tissue balance on the face, meaning the soft tissue skeleton has to match the bony skeleton. If you have an imbalance, meaning you have bone that's too prominent, teeth or alveolus that's pushing out, the lips aren't going to function properly. If the teeth and alveolus are too weak, the lip is not going to function properly. The lip has to have a balance with the teeth, meaning they have to be supported by them, not too long, not too short, not too far forward, not too far back. And this is how the eye works too. If you take someone's eyeball out, their orbicularis oculi doesn't work so well. If you have Graves' orbitopathy and the eye is bulging out, again, you start to get dysfunction in the levator as well as the orbicularis oculi muscle. So the mouth is no different. You do have to have a nice balance. And this just helps us in designing the lip lift to know that you should never worsen someone's strain. So the only contraindications that you have for a lip lift are someone has a strained appearance in their mouth, meaning they have mentalis hypercontracture, a high chin with a deep sulcus mentalis, DAO depression, hypercontracture, or anything where they have trouble closing the mouth, because the upper lip doesn't come down, it only goes up. So the lower lip has to close the mouth sometimes by pushing up, and you end up getting podo-orange, hypercontracture and issues like that. And if you do a lip lift on a patient with hypercontracture, they're just going to get worse. So you do have to be careful. The other is exaggeration in appearance. A lip lift will only make an exaggerated looking lip more exaggerated. So you have to really be careful with those patients with down pointed commissures and peaked central lips. So looking at the young, sexy lip, you can see, I don't know if you can see the pointer, but we have our M shape going all the way across, smooth internal arc, as I was talking about. The lower lip comes upwards and inserts into the commissure, just like you have with the eye and the canthus. So that's the look that you want to get, with the lateral part of the vermilion sitting on top of this exposed, not hidden. So that's what we try to gain. You do like to see anywhere between 1 to 4 millimeters of tooth show. You can have up to 8 millimeters of tooth show naturally on somebody, but iatrogenically, if you're forming tooth show, if you're gaining tooth show, you don't want to go over 4. People are going to have problems with mouth closure. Looking at the ratios, you have 2 different ratios that people talk about or worry about. One is the philtral height to the chin and the nose, and the other is the size of the upper lip to the lower lip. There is no specific number. Anything is fine that looks good. You just have to have good taste. The things that we do know in general is that the upper lip should not be bigger than the lower lip. So that's one thing where I say you can go up to 50-50, but you kind of stop there. Otherwise, you look like you have an underbite, and that's an imbalance. If you look at the height of the lip, you have to compare the philtral height to the nose and the chin. So when you're designing the upper lip length, you do have to keep that in mind, saying, okay, I just want it to fit into this face and envision how that's going to look. The other things we look at are a nice slope coming this way, nice slope going that way. So this is a steady slope that you want to have, not an exaggerated dip anywhere. And this itself, you just want to, again, have a slope that goes out into, from a concavity outwards gently and doesn't have too much of a vertical drop. When we look at these lips, you have to imagine, okay, how would I design a lip lift like this? That's the whole point of what we're talking about. So this is what I call the relaxed skin tension line globe of the lip. If you look at the relaxed skin tension lines, they're vertical, going out radially, and then become more circular as you get out to the nasolabial fold. I use these markings to design the lip lift. And what we use these markings for is to design the resultant lip border kind of like a puppeteer. So you're going to pull on one, you're going to pull on the C, drop the P, you can increase the I, and this will help with your lip design, controlling it. If you look at the letters, they actually spell out Cupid, so that's easy. So the central line is C, P is paramedian, I is intermediate, and D is diagonal. And all of these 4 are what control lip height. So if you have, or lip character. So if you have a low C or a tall C and a high P, you have an exaggerated Cupid's bow. If you have a P that the resultant height is similar to I, you're going to have a snarly looking lip where it looks angry. So you have to drop that I. If you have a D that's too tall, you have an exaggerated drop off on the side of the lip. So you can play with these 4 in order to gain lip balance when you're doing this. The other thing you notice is that when this patient smiles, there's a crease that forms in the subnasal area, and that's what I call the line of declaration, meaning that's anything above that line is what you can take in a lip lift in general. So it's just an easy landmark to look at. When we're designing the lip lift, we start with the subnasal markings. The markings stay in the crease. There's a peak here that forms where the medial crus or the medial foot plate diverges outwards and the sill comes inward. So where they join is this peak. It usually, but not always, coincides with the philtral column. So that's your P line. Laterally, you extend to where the crease finishes. You do not go beyond that. So you do have to finish it right there. If you go beyond the crease, you're going to scar. Once also this turns vertical, you don't need to go any more vertical. If you follow vertically, you're just going to create a scar, and it doesn't help you. So you just stop where the crease ends and never go past the vertical. So we mark the 3 lines. Now these are your diagonal line. The diagonal line is the internal corner of the sill, and you follow the relaxed skin tension line, which you can follow the pores of the lip, and it'll show it to you down all the way to the lip. And this is what helps your set up your design before you go mark the excision height. So the excision height is the next thing we look at. The excision height is always measured on tension. So you have to pull the lip while you're doing it. The residual height, which is what's left over here, is measured at rest, because visually you want to look at somebody and you want to see a slope between between the P, the I, and the D. That's a 2 millimeter slope. So that's the magic number. And I found this out because I was trying to teach doctors the artistry of lip lifting, and I realized you can't do that. It's not possible. You have to teach them numbers. So I said, okay, let me figure out if there's a calculation to this. And I got really lucky. There is one. And the slope, residual slope on an iatrogenically tampered lip should be about 2 millimeters. So that means between the residual height of P to the residual height of I to D, you should have 2 millimeter difference. So 12 millimeters, 14 millimeters, 16 millimeters. The height between the height of PC and P should be all the same, because there's a 2 millimeter dip in the columella usually, 1 to 2 millimeters, and there's a 1 to 2 millimeter dip right here that you see in the Cupid's bow that parallels that. So that's the magic thing, that's all. And we say, okay, how much tooth show do we want to get? That's what these markings are. If you do 4 to 5 millimeter lip lift, you get no gain in tooth show, you just get exposure. This is similar to blepharoptosis. So if you're doing ptosis surgery, 4 to 5 millimeters, you get like 0 to 1 millimeter improvement in your reflex distance. Here you see 6 millimeters gives you 1, 7 millimeters gives you 2, and so on and so forth. You do not want to do over 11 millimeters of excision, because you're going to have trouble redistributing the lower flap to the upper flap. So maximum you should ever take is 11 millimeters, and that's huge. If somebody has an exaggerated appearance or a propensity to look exaggerated, you don't want to go over 6, 7 millimeters. You really want to stay on the lower side of lip lifts, because you'll just exaggerate them more and more. So looking at this, I've marked out on this patient maybe 4 millimeters of excision there, and the residual heights of 12, 14, and 16. So those are the heights. And I just double check to make sure that the Cupid's bow has a nice soft look to it, and that's matching numbers, 12 and 12. So this is how you design it. You measure the residual heights, and this helps prevent a snarly looking lip. This helps gain symmetry. It helps everything. So this is what was missing in my original paper, was the residual lip height. So then we decide, okay, in my original paper, I said, don't do corner lips. I don't do them much. I was kind of have to eat my words. I went back, and for the past 2 years, I've been doing corner lip lifts on like 90% of patients. And it is necessary to get your revision rate down to 0, or at least close to 0. So the way I look at it is that diagonal line, we draw it. Anything lateral to that has a buried vermilion needs a corner lift. And there's 2 types of corner lifts that I do. Let me move my head over here so I'm not in the way. The 2 types of corner lifts, one of them goes past the commissure with an inflection like you would do in an upper blepharoplasty. And just like the upper bleph, you never go to the orbital rim. For a lip lift, you never go to the nasolabial fold. So the marking goes on the vermilion border and has an inflection that goes upwards, and that helps a down-pointed commissure look more neutral. This is a patient who already has that upward slope that I talked about and a nice insertion, so we don't want to exaggerate that. So her corner lift stops at the commissure. Otherwise, you can lift the corner too high. So I got to move a little faster. Sorry. The thing that I found out is that corner lifts are needed in patients who have a narrow nose relative to the lip width. So you see a narrow nose does not lift as much of the lip as a wider nose does. And it's because this is a subnasal lip lift. So everything's lifting up to the base of the nose. So wider noses relative to lips don't really need much of a corner lift. Narrow ones in general do, because you have that distance over there that's not being lifted. So here are some examples of lip design. And what I did on this patient was mark the central 6 millimeters, found out the residual was 11.5. So then I added 2 millimeters to it, marked this, which is 13.5, added 2 millimeters to it, marked this, which is 15.5, and everything lateral to that got a corner lift. This patient over here, same thing, and laterally just got a right-sided corner lift because the left side was already exposed. This patient got a little tiny corner lift on both sides because the lateral would not have been lifted. Here are different lip designs where you see you have a lateral bias on this patient, meaning she needs more from the lateral portion lifted than the central, and that's how you avoid central peaking, which is one of the problems you see with, I'd say, novices kind of starting in lip lifting. They lift the center too much. So you do have to measure out, and on patients like this that have an exaggerated Cupid's bow, you end up lifting 5, 6, 7 millimeters as you go out. So you're doing barely anything in the middle because you don't want to exaggerate them, and a big chunk on the side. The disparity between this and that can't be too big, but 2 to 3 millimeter disparity between the P and the D is fine. And we leave this slope of 12, 14, 16, and you can see the corner lift there is necessary to replace this white philtrum with red vermilion. Over here on this side, you see an Asian lip, again, is usually 5, 5, 5, and then 6 on the sides. So you lift more on the sides. Here's another exaggerated Cupid's bow. where we lift more on the side than the middle. And the other benefit of the deep plane is that when you get in there, you can reduce irregularities from fat injections and things like that. So I don't know if you guys reviewed fat injections, but fat does not naturally exist in the upper lip to any substantial extent. A fat plane, just like you find in the face, does not exist in the lip. So you do have fat stranding. You have a little bit of fat stranding within the SMAS layer, but there is no fat layer, which means when you take fat from someone's ass and you put it in their lip, you're doing something very, very unnatural and unpredictable. So you have to be cautious and not take that for granted and think that it's going to go well because fat grafting is natural. Fat grafting to the lip is almost as bad as silicone injections to the lip. It is very, very difficult to control. And I do it, but I do it to the smallest extent possible and very, very uncommonly. So very rarely do I do fat injection to the lip because it's unpredictable. It's much better to use a filler, which can be dissolved. When you inject fat in the lip, it immediately migrates upwards. It does not stay in the plane that you want it to stay. So here's an example of a patient who had an exaggerated appearing lip, or one that would have been exaggerated. So I lifted more in the middle, less on the side, you can see, and then added a big corner lift, and you can see how much balance that gave her lip immediately. Nice internal arc, more character to the lip itself. Here you see another exaggerated lip where the patient had a broad, snarly Cupid's bow and had lost the definition over time from filler. So I lifted more on the P line than I did on the I and the D line. I barely did any excision there, and this gave her her balance back. And here are some more examples. If you guys want to snapshot these, you can, but these will be in the paper. So the end result is you neutralize the corners that look like they're down pointed rather than exaggerating them. A regular lip lift would exaggerate these corners. This kind of lip lift, you can see that does lateral bias of excision, neutralizes. And you can see the same thing along all of these. So that's the basic gist. You see the down point on the commissure neutralizes, the lip is balanced and looking nice. So this is the same technique. Some patients like this that have an M-shaped upper lip, I do paramedian VY plasties, and that gives a smooth internal arc. And you can see how much sexier and more subtle that is than this M-shaped lip that's up there. The M shape is not a good looking lip. You want M on the top, smooth arc internally.
1 minute remaining.
Okay. So that's that. These are revisions. So this is the excision. You could find this in the paper. And anatomically, what you want to learn is if you look at the skin here, this is the epidermis, this is the dermis. The big chunk here is SMAS. So the SMAS of the lip is the largest contributor to what supports the skin. And you can see the SMAS here that I'm holding it. When you put dissolvers, hyaluronidase, into the upper lip, above the vermilion, you will shrink this SMAS layer to half its thickness. And there are doctors out there who they have their own imaginative kind of world that they live in, and they think that hyaluronidase doesn't permanently damage the SMAS. It's purely imaginative. It does damage the SMAS. And these are doctors who have never seen the SMAS. I've seen it 3,000 times here. I've seen it 1,500 times on a deep plane facelift. The SMAS is what contains most of your hyaluronic acid. So areas that have thicker SMAS, like the lip and the midface of the cheek, are very, very sensitive to dissolving. So you can damage it, and it can damage irreversibly. Yes, you do see rehydration in the first 2 weeks after dissolving somebody, but areas that have thicker SMASs, they lose their water retaining capability. So if you inject this with hyaluronidase, it'll shrink to half its thickness, and it can stay like that permanently. Some people rebound, some people don't. You cannot assume it would rebound. Areas like the under eye don't have SMAS. It's like the thinnest SMAS ever there. So you can dissolve all day, you're not going to create any problems. But areas in the midface and the lip, certainly you can. And what you would see and what you should look out for is after you dissolve somebody, you'll see that their upper lip looks dark. It's not hemosiderin deposition, it's deflation of the SMAS and lack of hydration in the lip. And if you go and put a benign filler in there, like Restylane Kiss or something, the tiniest bit will rehydrate that SMAS artificially, but it does it. But this is the thing that you should appreciate the most. And that SMAS is what, shrinkage of that SMAS is what leads to wrinkles in the lip more than anything else, more than dermal atrophy, more than anything else, is that SMAS layer. So this is why I was saying the deep plane is nice to see. You get an appreciation for the anatomy. And if this SMAS layer is overly hydrated, the orbicularis won't work. If it's poorly hydrated, the orbicularis hyperfunctions. And the same thing happens with the eye. If you have filler around the eye, it gets heavy. If you have fat retraction, or loss of fat around the eye can actually open up and you get, well, the opposite of ptosis. So I'll cut it short, but the technique is in the original paper, and then the new one will have all these kind of things. So sorry to take up so much time.
Thank you so much for sharing this with us. Fabulous pictures and great sophistications in your technique. So we're looking forward to review your paper.
Thank you. And I can forward this since I didn't get to finish it. If anybody wants this, I don't know how I can make it available to you, but I can give you guys the presentation. And then that way, if anybody wants to scan through it to see the technique, they can do that.
Thank you, Ben.
I'm sure Deborah will find the way.
We will find a way, yes.
Okay.
Thank you.
So Tanuj, it's your moment now. It's my privilege and honor to introduce you. You're like a big brother from the Stein family for me. Not only a talented and great oculoplastic surgeon, but you have been a true leader in this field. You have introduced all this young generation into the facial plastic world, and bring all this new vision on not only seeing beauty in the eye, but in the whole face. So thank you so much for that, and bringing the multi-specialty approach into this big world. So thank you for gathering us all here today, and thank you for having Avya here. So please, the screen is all yours.
Thank you, Jocelyn. When we put together the schedule, I didn't plan to follow Ben Talley. I was going to go before him. It's hard to follow Ben Talley. Wonderful talk, Ben. Thank you so much for sharing your wisdom. So just a quick word from our sponsor, Avya Skincare. This is a medical grade skincare line that incorporates Ayurvedic botanicals. It's available for medical practices that are cosmetically oriented. You can direct message me with any questions. And if you follow Avya, you'll be entered into a drawing for sets worth about $300 to $400 each that we'll mail to you. So I'm going to speak about autologous lip augmentation with fat and SMAS. I think one of the wonderful things about these kinds of meetings is you get different perspectives. And I think Ben's comments about volume in the lip is correct in many ways. I think that lip augmentation with fillers or fat and SMAS is an artificial way to address the lips. But I do find it a useful tool in my practice, and I'll discuss some of my techniques here. So for those of you around the world who don't know where Austin is, we're in the southern United States. We would welcome you to come visit us. We have a practice of 6 oculofacial plastic surgeons and 2 fellows, and we'd love to teach, so come visit us. We'd love to have you. So we've been talking about volume loss throughout the face. That's the topic always at hand when we're talking about volume. And in particular, the lips do lose volume with aging. I think that one difference in Ben's population and my population is my average population patient age is over 50. I think his population is younger. So one of the things that happens with aging is volume loss, and volume loss throughout the face can be treated with fillers. This is a patient who did not have surgery. This is Botox and fillers alone. And we can see that the power of non-surgical rejuvenation is very high. But there's pros and cons to permanent volume and temporary volume. And I do have a preference for treating with permanent volume when possible. It turns out to be a value added option for patients, and certainly it's simpler in the long run for them. I use fat transfer for volume rejuvenation when there's not distinct congenital issues with the lips. And I use implants and grafts for congenitally thin lips. And so let's talk first about autologous fat transfer, which has the power to make substantial changes throughout the face. I'm not going to go into the harvest technique very much, other than to say we use standard tumescent technique and harvest from the abdomen and the legs. I like to centrifuge the fat according to scientific articles that have shown us that 3000 RPM for 3 minutes does increase the longevity of the grafted fat cells in animal studies. The ideal lip contour has been discussed a lot over the last hour. I won't spend that much time on this other than to mention in general, and of course, as has been mentioned before, each patient deserves an individualized approach. In general, I like to use a 3:5 ratio between the upper and lower lip, and volume augmentation of the vermilion border should really be limited to the medial 60% of the lips to avoid an artificially expanded lateral modiolus. Rotation of the lip in the central area increases the mucosal show, which adds to the beauty and the sexiness of the lip. So with autologous fat transfer to the lip, we enter in through a lateral 18-gauge entrance site, and I'll basically place the fat into 3 planes. This is the central plane where I'm augmenting across the entire lip to add general volume to the entire lip. And now we're going to go along the vermilion border and inject in that medial 50 to 60% to get vermilion border expansion. And now we're in the posterior aspect to be able to achieve rotation of the lip and increased mucosal show. It's important to inject the fat in a smooth manner, of course, and then simultaneously injecting in the pre-chin area, the pre-mental space. The pre-gel space allows for soft tissue augmentation to enhance proportion and filling the mandibular ligament. So this is a 1-year follow-up of a patient who had fat transfer around the mouth with some laser surfacing. And we can see the power of permanent volume augmentation for the perioral area. So what about patients who have congenitally thin lips, like this patient here? Alloplastic lip augmentation has been around for decades with silicone or Gore-Tex implants, and certainly there may be a role for these types of implants. I prefer to use autologous tissue whenever possible. There are so many advantages to using the patient's own tissue. Not only psychologically is it more acceptable to them, but the final outcome has less complications, feels better to them and to their loved ones. So by harvesting fat using a standard facelift approach, once we've accessed the subcutaneous space, we can then separate the SMAS from the skin and separate the SMAS from the deep layer using standard approaches, and then simply resecting SMAS for use in the lip area. Here's the SMAS flap being elevated. We can get lengths that are up to 6 to 8 millimeters, really any length you need to perform this autologous graft. And so the basic steps are stab incision in the lateral modiolus with a blade. And this incision should be about 0.5 centimeter. And these are the same steps that would be performed for a lip implant. We use a spreading dissection with a scissor to get across the lip and to create a pocket. And then we pass a forceps or a Takahashi or curved Takahashi through to be able to pull the lip graft into place. I'll show you a video of this technique here. Here's a patient who has an 18-month post-op of lip augmentation with a SMAS graft. And we can see how beautiful this can look long-term. This is better. There's no nodularity or firmness, and it has give and mobility just like a normal lip would. Short video on SMAS augmentation to the lip. We start by injecting local anesthetic to the lip. And then here's our lateral stab incisions to allow access for first a sharp-tipped scissors with spreading motion to create the initial pocket through the lip. And this comes all the way across to the contralateral side. And then we transition to a blunt scissor to get wider spreading in the pocket to allow for easy transfer of the graft into the pocket. Here's a purpose-made curved Takahashi that is brought through the lip all the way across. And then the SMAS graft that has already been measured for the appropriate size for this patient has been now brought through the lip, and we've measured the length of the graft so that we can ensure that we're placing it in a centered location in the lip. And then once we're satisfied with the location, we will close the incisions using a 5/0 chroma gut suture. Here's some additional post-ops of SMAS autografts to the lip. Long-term post-ops demonstrating the power when it's combined with a facelift. So in conclusion, I feel that autologous tissue has distinct advantages over alloplastic material. I think that fat grafting is a wonderful way to offer permanent soft tissue augmentation that is most useful for rejuvenation of lips that were congenitally normal. And in contrast, SMAS is an ideal, more dense autologous graft for modification of congenital anatomy for thin lips. And just wanted to invite everyone who would like to travel to Austin next month. We're having a live meeting honoring John Shore, who's the founding member of our practice, who's now retired. And we're having Bob Goldberg and George Bartley present as our keynote speakers for this 2-day conference. Thank you very much.
Wow, that was fantastic. And looking forward to hear about all this Q&A discussion now. So to lead us with this is Robert Schwartz, and he's also one of the prodigy sons of UCLA, and Dr. Goldberg and Dr. Shore, and well, an outstanding oculoplastic and facial surgeon, and he's famous in New York and all the world for this unique talent in mastering and teaching also cosmetic complex techniques. And you know, he has a sophisticated eye for natural results. So let's go ahead with the Q&A, Robert.
Thanks so much, Jocelyn. Appreciate it. Big virtual hug to Ben and Tanuj. Great job. Fantastic. First of all, Ben, thanks for making your talk relatable with a lot of similarities with the orbit and the mouth, and I appreciated that. First off, I had a quick question for Ben. If there was an overfilled lip, let's say either with filler, fat, or even Gore-Tex or an alloderm implant, how would you address that before doing a lip lift? Would you remove it? Would you take that into consideration? Would you remove it ahead of time, let it heal, and then lip lift? How would you address it?
So that situation comes up a lot in patients who need lip lifts, because if they've been overfilled, they fall into this accelerated kind of aging, and they end up needing a lip lift sooner in life. So I do see a lot of those. The part that I messed up on a lot was if they came in with fat grafting or silicone, sometimes they'd have filler on top of that as well. And with silicone and fat, sometimes you get migration, you get hypertrophy. With silicone, it can go up about 2 centimeters up the lip. Fat, if it ever migrates, is just when it was injected, someone injected too hard and it went above the vermilion border. And the mistake I was making there was dissolving those patients before doing a lip lift. The reason that's not good is you're gonna deflate the SMAS layer substantially, and you give a dry appearance to the lip, even though they maintain this hypertrophic granular scar tissue in the lip. So doing that, I caused a lot of problems in patients where I deflated their SMAS, their fat and their silicone problem was still there. And then I went in the lip lift and lifted them, and they ended up getting these like indents in the lip that I had to refill, and it becomes a big problem. The SMAS layer, you really, really need it to support the skin. If I'm sure and certain that they don't have fat causing that kind of thickness to it, or silicone or anything like that causing it, then I dissolve them. And I dissolve them 2 weeks prior usually. I'd like to do it months prior, because you want to give as much time as possible for the SMAS layer to rehydrate. But people don't want to walk around all jacked up and, you know, bruised and deflated with no lip. And it's a pain to go re-inject everybody. So I just do it 2 weeks before, deflate them. And I use Vitrace, which is the one from the lamb testicles. You know, it works really, really nicely. And what I do is I draw 20 units of Vitrace into a 1 cc syringe. So it's just 2 parts of it is Vitrace. The rest of it is lidocaine 1% and a little bit of bicarbonate. If you don't put the bicarbonate, the dissolver burns like crazy. So everyone's like burning dissolver is the worst feeling in the world. It's really not if you put the bicarbonate in there. And I put a long 30 gauge needle, so like a 1 inch or 1.5 inch 30 gauge. That way, when you're injecting, you don't just dump it all in one place, because you really don't need that much dissolver. And I don't want to over dissolve somebody, because again, you're damaging their SMAS. Guaranteed you're damaging their SMAS. So how much are you damaging it? Is it just a little bit, you're not going to notice? Or is it going to really deflate them and never recover? So you really do have to be careful with how much dissolver you're putting in there. A little dissolver goes a very long way. And likely you don't need to fix anything because you barely damaged their SMAS. You're just getting rid of the filler. So I do it 2 weeks prior. I see them back 4 days later to make sure I got everything that I want to get. And then during the surgery, on occasion, if I over dissolve them, I have to put some filler back into the philtrum. Otherwise, you get pleats and indentation in the skin.
Another
Ben,
question.
I think your point of dissolving and damaging the SMAS is a real one. I'm very glad you brought that up, and I think it's a very important message for everyone. Do you think that some of your experience may be related to the fact that the dissolving was right before surgery, and if you gave this person 6 months, they would have naturally expanded a little bit?
No. So what I'm talking about is long-term stuff. So yes, if you give someone time, they will rehydrate. And in many cases, you haven't caused a problem. What I'm talking about is patients who have had it 5 years prior, 4 years prior, and I go in there and they have the thinnest SMAS. And I know it's not the natural thickness of their SMAS. I've seen so many of them. I know, you go into the face and you see someone who's been heat damaged by Ulthera 20 times, that SMAS layer is not supposed to be that thin and stuck to the skin. So you do see that with someone who's been dissolved in the past. And with gentle dissolvers or with somebody who's resilient, they recover. Just like you do a CO2 laser, you damage the collagen, but it recovers, it recuperates. And hyaluronic acid, you don't have that much in the SMAS, but a tiny bit of hyaluronic acid naturally pulls in 1,000 times its weight in water. So these molecules are super, super important. Most cases, when you dissolve somebody, it does not cause a problem. Okay, so because we're not putting a ton of dissolver in there. However, there are many, many patients that will have permanent deflation and darkening of this upper lip, a little depression, a little wrinkle, but it's the darkness that you see in there. And as soon as you reinflate it with a little bit of filler, the color goes back to normal, which means it was not hemosiderin staining. People think it's hemosiderin staining that just stay there. It's a deflated SMAS layer. The opposite spectrum, or the opposite end of the spectrum, is overfilling. And you see this mainly with Juvederm. When Juvederm is overused or it migrates upwards, you get a white color to the lip. It's a white discoloration. It's not a Tyndall effect. It's a white discoloration and a crystalline appearance. So that is overfilled, too much in there, and then dehydrated is the opposite, which is dark. And the vermilion can change color too. So it's not just up here. If you put Juvederm too much in the lip, it'll turn whitish and it gets patchy. If you dehydrate it, it gets darker. If you have it in a perfect balance, it's this beautiful rosy color to the vermilion.
Great. With regards to surgical planning, do you change anything if there's a very, let's say, wide base alar base, or the sills are too wide, or let's say the columella is not as stable as you'd like? Would you change it? And with regards to the inferior dissection, do you change the amount of dissection you do because you're creating a flap onto a stable base?
So I used to change the amount of dissection I did depending on how much lift I needed, and because the more you dissect in the deep plane, the longer your healing is going to be. The problem I have is once you feel that deep plane release, whether it's in a facelift or in a lip lift, I can't not have that. I have to have that every time. So I do a full dissection, even on a 4 millimeter lip lift, where I'll release the SMAS all the way down to the commissure, and in the midline, I come about 2/3 of the way down. And I grab the SMAS and I stitch it up to the piriform ligament, which is the decusating fibers that exist over the periosteum. You never grab the dermis of the nose because that's loose and it'll pull downwards. So your suturing is from SMAS to piriform ligament. If somebody has a wide nasal base, that just means they might not need a corner lift. It doesn't change anything otherwise. But if somebody's had oromaxillofacial surgery, or they've had rhinoplasty and they've had the alar sill tampered with, they have a bit of laxity there that naturally isn't. And when I'm doing my suturing, I have to think, okay, 5 years from now, that, or even a year from now, that sill might drop because of my lip lift. So what I do in those cases is I throw nasal base suspension sutures. I grab a 4.0 PDS and I go inside the nose and I just mattress it out through the muscle junction of the nose to the lip, and I mattress it back in. And that helps suspend the nasal base. The other cool thing it does, and this is getting into like advanced parts of aging, is the orbicularis muscle as you age goes out in a clockwise fashion. So if you know oral surgery, it's a clockwise fashion the muscle loses its insertion at the nasal base, slowly comes down and outwards. And when you want to reset that and resuspend someone's nasal base, just those plication sutures will give you counterclockwise rotation where it rotates back into the base. So it is nice for improving the muscle insertion. And you have to know the difference between nasal base suspension and muscle plication. So nasal base suspension just gives you some, like a scroll of strength at the base of the nose and resets it. Muscle plication, you're actually shortening the muscle height and you are obliterating whatever muscle you plicated, you're fibrosing it. So when we look at muscle height and you're looking at the lip lift is the volume. If we're comparing it to like volume and gain, lip lift is the volume. That's what's going to give you the majority of your external shortening and incisive display. But if you need more tooth show without cutting away more skin, you turn up the gain, and that's the muscle plication. So you can actually plicate the top of the muscle to the nasal base, and that'll lift you a little bit more. So sorry for the long answer, but it's complex.
That's fantastic. I'm going to start to get to a couple of the questions. There's a whole bunch from the audience. Dr. Thapa is asking, he said, excellent talk, which I agree. How do you address a broad lip if your patient asks it to reduce it? How would you reduce the lip?
This does happen a lot in the Black patients and Asian patients. They generally have a large vermilion already and a lot of display, and then they just have a long upper lip. And anytime you lift somebody over 4 millimeters, you're going to increase the volume display of the upper lip. So you're not increasing the volume, you're increasing the display of it. So the height of the vermilion that's exposed gets taller. The other thing that you get is squamous metaplasia. So you'll see that when you lip lift somebody, they get dry lips for even up to a year. And that's because the wet mucosa, the wet dry border has to turn to dry mucosa. So at that wet dry border, if we need to reduce, I make a marking right there and I reduce behind it. And that keeps you pretty safe. So you're just cutting out mucosa and submucosa and you stitch it back up with 5-ochromic sutures. If somebody has silicone hypertrophy, that's different. You're going to have this yellow, oily, granular layer that's in there, and you don't want to cut out much skin. What you want to do is elevate a mucosal flap on top of it, and you snip away everything that's naturally not between the muscle and the mucosa, which is that granular scar tissue. It's yellow. So I do that, and then I close it back up. Usually you don't need much actual mucosal reduction, but I like to do it at the same time as the lip lift if it's obvious that they're going to have that issue. If not, and we don't know, and the patient might be fine with it, then you just leave it for 3-4 months, wait for the lip lift to settle because it takes 3 months for it to settle, and then you can do the excision. The other thing that someone had asked is the healing time. A deep plane lip lift is very traumatizing to your lymphatic drainage system. You're completely disrupting it. So for 3 months, the patient can look awkward, and you really have to walk them through it. I have a 4-page sheet that I give patients that keeps them from calling me and annoying me. So there is a 4-page sheet that tells them, at week 1, you're going to look huge. Week 2, you're going to look halfway huge. Week 3, you're going to get, instead of having soft swelling, you go to firm swelling. So you get this firm induration that occurs in the muscle up in the philtrum. At 2 months, you're halfway through that. The nose is still a little bit wide. You're still asymmetric. At 3 months, you look amazing. So that's what I tell them in general.
Okay, that 4-page sheet is phenomenal. And if I could steal it, that would be
I'll send
amazing.
it to you right now.
And then finally, I have a question from Erica Smolin in my hometown of New York. How does a lip lift work? How do you determine what shape is best for someone, keyhole, lip lift or not? And do lip lifts affect elasticity over time? Like, is it better to wait when you're older? Question mark.
So as far as the design goes for the upper part, so the vermilion border, that's that slope. So you want to have the C and the P being the same height, and then 2 millimeter difference between I and D, and then a corner lift on anything lateral to that, and that gives you nice exposure. And this is one of the procedures where I hate when people say like, this is what something should look like, because nothing, there's no definitives in this world. Like beauty is, you can look at it a million different ways, but with lips, if you're tampering with it, that keeps you safe. As far as the vermilion goes, I don't like to create something that naturally doesn't exist unless I need to soften a harsh appearance. So when I do plastic surgery in general, I'm looking to make someone look more pleasant and soft. If there's an aggressive feature like an M-shaped lip, I have to soften it to make them look like a nicer person. So I do those little paramedian VY plasties. However, for things that go towards the tubercle not existing, or the central tubercle being indented, which is a keyhole, or things like that, I don't like to go that far. I leave it as is. The more creative lip techniques like that, they tend to cause problems that we can't fix. So I really try to limit what I do in terms of like changing someone's lip design. And the elasticity doesn't change with a lip lift. You can drop the nasal base a little bit if you don't secure it well. That's the thing you have to worry about. But as far as the lip itself, if you do a deep plane, you placed everything back anatomically correct, so they should be fine. If you don't do a deep plane and you just do a skin excision and then you pull up the skin to the base of the nose, you've imbricated the muscle that's there. It folds over onto itself and you fibrose. Instead of 3 millimeters, you fibrose like 6 millimeters of muscle. So you can affect the orbicularis function. If you affect the orbicularis function, you will age more rapidly because you lose the tonicity in the lip and it's not holding itself up anymore. And that's why fillers age people's lips faster. You have a little bit of an expansion, sure, expansile effect, but your function of the orbicularis gets impaired when you have overhydrated philtrum. So Juvederm is injected on the border, it immediately goes up about 10 millimeters. It can migrate, and that whole 10 millimeters of lip becomes incompetent. It doesn't work so well anymore, and the lip just hangs and it loses its tonicity, so they do age faster.
I'm sorry, that was great. That was fabulous. It was a great session, but it's time to transition now to the next session. Thank you, Jocelyn. Thank you, Bob Schwartz. Thank you, Bentalay, and thanks to Tanuj as well. And it's my turn now to introduce my friend, Dr. Sabrina Shah Desai, who has taken her role as the lucky mascot of GCS really seriously and decided to wear a lucky mascot cap as well. Sabrina Shah Desai needs no introduction. She's probably one of the best known oculofacial plastic surgeons from United Kingdom and the European Union. And Sabrina, we are privileged to have you with us once again.
Thank you so much, Debraj. Yes, I did decide to take my role very seriously. I had to get my son to fish out one of his costumes. So welcome everyone to where we shift gears and we move from the lips up to the nose. So welcome to the non-surgical nose session of the Global Cosmetic Surgery Nose Lip Masterclass. And I'm delighted to have Dr. Ho Seok-sa from Seoul, Korea, who is the moderator for this session. So welcome and feel free to jump in and help moderate and ask us questions. So we all know that non-surgical rhinoplasties, or the liquid nose job as it's known, has been on the rise and it's extremely popular. However, it comes associated with a devastating risk, and that is the risk of blindness, which is quite high. And over the years, there's been a lot of changes that have occurred, and a lot of people using ultrasound, a lot of people now using threads to address the nasal tip to minimize that risk of nasal tip necrosis and reduce blindness. So we have two doyens who Debraj and Tanuj have very kindly organized for us. And my pleasure to introduce the first doyen, who is Dr. Konstantin Solamandes from Georgia. And he is one of the founder creators for Aptos Threads, and he has got a significant worldwide experience and talks on the use of threads for nasal lifting. So without further ado, Dr. Konstantin Solamandes, I will let you take it away.
Hello, everybody. It's a big pleasure for me to be here with you, even online, and I hope that soon we will have possibility to see each other in real life. It's a big pleasure and a big honor to be a part of this conference. And I want to share my screen now and start my presentation. So my theme today is about nose correction with threads. I'm a plastic surgeon. I do rhinoplasty in my practice. I prefer closed rhinoplasty. Last 3 years, 4 years, I use most of all let down and push down techniques. But in some cases, in post-traumatic or secondary rhinoplasties, I use also open approach, around 10% of all cases in my practice. But this is surgery, of course. I also use minimal invasive methods, fillers, toxins, threads, but fillers for last, I think, 1 year, I used just few times, and I think my colleagues will speak, next speaker will speak more about fillers, and he has more experience with this, with fillers, but I will speak with threads. So we know that a lot of procedures are just you can see from 2018. You can compare nose reshaping by a surgical method, rhinoplasty, and nose correction with minimal invasive, and you can see that 3 times more worldwide we are using more minimal invasive techniques. But of course, we have some risks. I will go fast with this slide because I think my colleagues will speak better. And of course, we know that we have a risk of blindness and necrosis and embolization. And not only with fillers, you can see that by statistics, also 47% of all embolization happened with autologic fats. My father in 1987 invented barb suture and presented thread lifting method as a method for face tightening and face reshaping, soft tissues reshaping. And this is how what kind of thread we use today. And this is the thread that I use also for the nose, not only for subcutaneous lifting. I use 12 centimeter long thread with opposite direction. Barbs are opposite direction, and the thread is preloaded to a cannula, which is also 12 centimeter. And I use around 5 to 6 threads for one procedure. Of course, I use absorbable thread, and material is L-lactate caprolactone acid, which starts to absorb in 6 months and finally absorbs in 1.5 years. You can see histological pictures. With threads, we can create volume on the nasal bone to increase nasal bone. We also can lift a little bit the tip of the nose. We can correct tip and lip angle. In some cases, we can correct nasal tip deviation, but in case if the septum is straight, and in some cases, we can also correct nasal valve problems. Unfortunately, with threads, it's not resultative to use them for wide tip or wide nostrils. I want to show you the marking, and I want to explain that during last 10 years, we are using threads for the nose in our practice, in our clinics. And we started with loop technique. We started with creating a tension on the tip of the nose, but we understood that big tension sometimes gives problems of conturation, and sometimes it can damage also, the thread can damage the cartilage of the tip of the nose if we create too much tension. That's why we switch our approach to not to create a big tension, just to fill some areas of the nose with the same method as we are filling nose with filler. But in this case, we are using hard material, which structure is very similar to elasticity of the cartilage. So it's hard material, and we can use it like a graft, because during rhinoplasty, during structural rhinoplasty, we use grafts for the creating of support of the tip of the nose. The same technique I use here. So you can see that I use one entry point from the tip. In this case, patient is under general anesthesia, and you will see later why. But in 100% of all cases, I use local anesthesia with 0.5 lidocaine, 1% with adrenaline, and this is enough to have good anesthesia. You can see that I'm just moving straight and back, and each time I move straight and back, I leave a part of the thread under the skin, above the cartilage. And also I use cannula, so I'm not damaging the structure of the nose and cartilage of the nose. You can see also that there is no tension on the tip, so I can press any place and it's very elastic. So why I do this operation under general anesthesia? Because patient was allowed to make this small experiment. He came to me for surgical rhinoplasty, but we started with threads to show how the threads are placed under the skin. Normally, I make dissection in subperichondrium plane, but in this case, I made dissection in subcutaneous plane to show you where are all threads localized exactly. And you can see that all threads are very fixed between the cartilage, exactly in the area where I want to create a volume, like a columella graft, as we are doing during surgical rhinoplasty. You can see that the barbs are fixated very, very nicely to the soft tissues, and at the same time, it's very easy to remove the thread during rhinoplasty. So if we surgeons, during rhinoplasty, we will see some threads under the skin, this will not be a problem for us and for our rhinoplasty. Of course, I continue dissection. I cut Pitangui ligament in this case, and I removed all threads from the nose. Here, I want to compare two patients. Intraoperational videos. You can see that on this video, I found a filler during my rhinoplasty. And this filler is it's very soft. It's like a liquid, and it just creates the volume. And it has no any possibility to create a hard volume and to create the volume exactly in the area where we need. And now you can compare it to the thread that are also creating the volume, but this volume is strong, this volume is hard, and which is the most important thing, with the thread, you will never have embolization of the vessel, and you will never have blindness or necrosis problems. You can see how nicely it creates the volume above the cartilage of the tip of the nose. Now I want to show you some cases. This is before and right after. Before and right after from the semi-profile and straight. One more case. Here I want to show you the video. This is before and right after. We always have very natural form after such procedure, and you can see that the tip of the nose is very, very elastic. I can press to the tip and it comes back to the same area. In case if you are using loop technique and you are creating big tension for the tip of the nose, you will not have this elasticity on the tip of the nose. But with this technique, I call it thread grafting. It's the same technique as we are using grafts for the tip of the nose. So in this case, we have normal elasticity. One more patient. This is Asian type of the nose. You can see that I increased the bony part, the bony pyramid, and also lifted the tip of the nose. One more case, 2 years after, and you can see that we still have very nice volume on the bony part of the nose. You can see before right after, and 1 year and a half. So the result is very, very stable. Even when we have total resorption of the thread, we have fibrosis tissues, and we have memory of the cartilage, memory of the tissues that also creates some result even after we have resorption of the thread. This is before and 1 year after, before and even 2 years after. Of course, I'm not promising patients the result more than 1 year and a half. I'm telling them that the real stable result will be maximum for 2 years. Now I want to speak about secondary rhinoplasty cases. You can see that this patient underwent 3 rhinoplasties in different clinics, and she came to me with pinch deformation, with nasal valve problems, external and internal, and she told me that I will never do again rhinoplasty. Please make for me filler. And I told that it will make a big risk of embolization, because after rhinoplasty and after traumatization, the risk of embolization is even more. So I told her that we can do something with threads. But what we can do here with threads, because I showed you only tip elevation method, but sometimes we can feel some areas of the nose, some dimples and irregulations of the nose. And sometimes when we need to support nasal valve, we can use this thread as a rim graft. I think my colleagues also know rim graft technique, when we insert very thin and small piece of cartilage that we can take from the septum, for example, to the rim area to create more support for the rim and to decrease pinch deformation. So this is before and 3 months after. Of course, it was very difficult to have big correction, to have a big result, strong and nicer result than this. But this patient was really happy with even this correction. One more patient, young lady, only 25 years old, and she underwent rhinoplasties 4 times in different clinics, and she came to me also with the words that I will never do again rhinoplasty. Please make for me filler. I told her that it's impossible because it's a big risk. But the main problem was her nasal valve during forced inhale. You can see that left nostril was totally collapsed during forced inhale. So I used the same technique as I showed you before, as a rim graft, the same idea, but with threads. And you can see before and right after, nostrils are very, very open. And what is very important is during forced inhale, you can see 2 weeks after, and nostril is totally open. Of course, here we have also some edema swelling, which also helps to support the nostril. But she came to me also 8 months after, and this is her stable final result. And she is really happy. Okay, she is really happy because now she can breathe without collapse of the nostril. I also used these threads to feel some deformations of the nose, and you can see that now the shape of the nose is a little bit better. So she was really very, very happy. We do a lot of rhinoplasties in our clinic, and also we are using a lot of threads, but also only we have 8 cases of complications with threads for the nose, and all 8 cases was inflammation. This is, I think, the biggest risk of using threads for the nose, but we will never have any necrosis, emboli, or blindness. You can see one case of infection. This is 1 month after the procedure, and small video how I removed the thread. It's very, very easy to find the same entry point, to find all threads. I checked in her documentation that I used 4 threads, and I found all 4 threads. I removed them, and this infection stopped. All this process stopped right after I removed the threads. So it's very easy technique. It's very easy to understand. Just we need to understand that we don't need big tension. We need just to feel some areas of the nose, and we need to support some cartilage to have really very nice result. Thank you very much for your attention, and I hope you liked this technique and you will use it in your practice.
Thank you so much, Dr. Suleiman. I know we're going to have lots of questions on this. Certainly, I do have lots of questions, but excellent results. Just keen on knowing what you do after the 2 years, and when you do fillers or more threads, what does the tissue feel like, and how challenging it can be with the internal scarring. But we'll approach that, and I'm sure Dr. Hosyuk is going to look at the questions that will come flooding in. So it's a great pleasure to introduce our next speaker, Dr. Alexandra Rivkin, who is a world-renowned cosmetic surgeon based in UCLA, and he's also an assistant clinical professor at UCLA. He's much published. He's also published on calcium hydroxyapatite in the nose, and he's the inventor of the non-surgical rhinoplasty. So it's a great pleasure to have you share your pearls of 20 years of using fillers in the nose. Over to you.
Thank you so much. Thanks. Thank you so much for having me. It's a pleasure. Let me see if I can share my screen here. Yep. Okay, great. There's that. There's that. And okay. Wait. There. Okay. Got it. Okay, you guys can hear me? I assume.
Yes, go ahead. Perfect.
Okay, great. So I'm just going to present a little bit about non-surgical rhinoplasty, and I do it with fillers, and I've been doing it for a while, for 17 years now. And I just wanted to, first of all, to start out by saying that I consider myself an artist, and I hope you guys do too, because what we're doing every day is art, and we use our talents and our knowledge to create, and what we create moves people and it really affects them, and that's what the best art really does, right? And so this is why this procedure in particular is my favorite of all the things I do. Probably do about 6 times a day, and it never gets old because I can always see the impact that it makes in such a short period of time on people and on people's lives. Every week, someone cries from joy after seeing their new nose because they've just been thinking about it for such a long time. And so your patients are probably asking for it, and because they see it all over Instagram. But as we've spoken about, and I think has been emphasized previously here, and as you guys all know, the nose is the _1 most dangerous place in the body to inject filler. I don't think there's any other place that has more risk. Which is a true statement, but which is not to say that it is, I mean, it's still quite rare to have, adverse events happen in the nose. It's just it's considerably more common than in other areas of the face or body. So it does happen to be the #1 cause of blindness with filler injections. But there's dentists doing it, there's estheticians doing it, depending on the country, depending even on the state. There's a lot of people doing it because it's just something that is all over Instagram, and people want to get in on the on this procedure. Unfortunately, it looks a lot, when you see it done on Instagram, it seems very simple, and people don't understand the inherent risks involved. And so, you have to, when you're thinking of starting to do this procedure, you really have to learn everything you can about it. And so I'll give you some of the things that I've picked up over the years, and hopefully that'll help. So my disclosures, I speak for all the companies and research as well, and consult. So first tip is that if you're going to, as the previous speaker spoke about quite well and made this point quite well, I agree with him very much, is that if you're going to try to change the aesthetics of the nose, you have to create a visually pleasing structure, right? And that structure needs to be stable over time. That's really hard to do with soft, hyaluronic acid fillers like Juvederm, for example. You have to use something more firm, more sturdy. So I prefer the thicker HA fillers, fillers with high cohesivity and high G prime. So I can project tissue and I can create defined edges and lines with the injections up to a point. So I also like fillers with good duration. Nobody wants to have their nose injected every 6 months. It's not particularly, it's not that big a deal with the eyelash. And I'll show you how I do it. It's not terribly uncomfortable, but it's still, not something that you relish going to every 6 months. So you want something that really lasts a long time, and you want something that's reversible, because reversibility gives really patients peace of mind. That's why HA really my preferred material. Calcium hydroxyapatite is good also for extra lift, but it really doesn't last as long as the really long-lasting HA fillers, and it's not reversible. So second tip, communication. Communicate with your patients. This is obvious, but in the nose, it can be not so obvious, right? So patients come in with a big bump. My first instinct is, for example, to refer to surgery. Say, oh, no, I can't do this kind of thing. This is too much for fillers. But once I start speaking with them, it becomes fairly clear that in their mind, surgery is off the table. They're not interested in it. They just want some improvement, and they just want a good enough nose, which fillers can do. So, they do the procedure, they're ecstatic with the results. It's not perfect by my eye, for sure, but it's better, and that's all that they want. They don't want surgery. So what the patient wants may not be what strikes you as most aesthetically important. Some people want to keep the bump and look like, continue to look like their family. They want to maybe continue to have a curve to their nose, and so because they're concerned about erasing their ethnicity. So all of these kinds of things need to come into the consultation, and you need to talk about that. So with this example, this is a guy who is difficult. He's had quite a curve to the nose. And so I needed to raise both his tip and his radix in order to overcome this curve. The point was I need to make sure that in doing so, however, that his radix wasn't going to be too high, that it was going to give him a Roman nose, and that his tip wasn't going to be super over rotated, and managed to do that by injecting here and here using calcium hydroxyapatite. And this was a long time ago when I was still using primarily calcium hydroxyapatite. But even now, in this kind of case, I would probably still, see what I can get done with a filler like Voluma, and then we use the calcium hydroxyapatite as well. So one of the things I could have done was inject the Voluma, inject the Columella to lift up the tip a little bit higher, but I didn't do that because it would have given him too much of a hanging columella. So I wanted to avoid doing that. Now, if you look at the before and after, I'll take the syringes away, his nose actually looks, to my eye anyways, maybe I'm a little bit biased because I'm enchanted by my work, but nevertheless, I think his nose looks smaller, and we'll talk a little bit more about that later on. So this is a pencil drawing, right? It doesn't look like a pencil drawing. This looks like a photograph. But the point being here is that this drawing is so detailed that our eyes see it as flawless reality. And this is the same principle that I think you should think about with all aesthetic injections, right? Obsessive attention to detail can give natural, perfect looking contours, even if viewed from close up. This is especially important for the nose. It's a midline structure. Our eyes are exquisitely attuned to how straight, how defined, how proportional and how symmetric it appears. So tiny contour adjustments in just the right places can really transform a decent result into an absolutely outstanding one. And to that end, I've changed the tools that I use to do this procedure. And I now inject with these tiny little Botox syringes, these diabetic BD syringes. And I'll show you how I do that in the next video. Let me see. Okay, so I'm going to demonstrate the technique to transfer Voluma from the regular 1 cc syringe into a 0.3 cc 31 gauge fixed needle BD insulin syringe. Okay, so first thing is I take a 21 gauge 1-inch needle and put that onto the Voluma syringe, so it's nice and snug. Then I take the plunger out, so everything's still sterile, right? Put the needle through into the syringe again, remaining sterile. I'm going to move on. So now I'm depositing Voluma into the syringe. At this point, we've got about 0.2 cc's, like that. Don't want to overfill it, so I'm going to stop there. And recap. Those are good finger exercises. Put the plunger back in. Good, and then it's ready to go. So, and you can see that the Voluma comes through this needle really quite easily. Can you see that on the video? No? Pull back a little bit. You'd think that so that's enough for that. You'd think that a thicker filler such as Voluma is going to have a hard time going through a real tiny needle like that. It really doesn't because of the rheology of that small syringe. It goes through very easily and very smoothly. So this way it's more, I can be more precise because I'm injecting tiny amounts. I can also be safer because I'm injecting tiny amounts and because I'm doing so under relatively low pressure. It's considerably more comfortable for the patient, and also there's a decreased risk of bruising. So I really like using this particular syringe and needle, and I think it works quite well for the nose because you don't need to put large amounts in the nose. My average volume is about, maybe 0.3, 0.4 cc's, right? So let's go on. So this patient's nose, look, attracts attention because of the curve on the profile, right? It looks bigger than it should because of that curve, and because that curve attracts the eye of the viewer to her nose, and it looks considerably bigger. When it's straightened like this, and I put injections here and here, it blends into the rest of the face. It looks smaller, looks better proportioned. And so what I'm doing is adding to the nose and making it look smaller. And I think everybody that has been doing this procedure for a while can see that that is a phenomenon that happens all the time. And it's really quite nice. It's a little tricky to explain to patients, and they're like, you're gonna make my nose bigger. And I'm like, no, I'm actually making your nose smaller. What? Okay, but you can talk to them about it. So precision really comes into play with post-surgical noses. So you're filling tiny indentations, adding to one side or the other for symmetry, making smooth transitions, camouflaging cartilage edges, and all these kinds of things. Really, you need to have very, very fine precision in order to do that kind of thing successfully, and in order to do that kind of thing where it looks natural. So transforming a nose that looks done into a natural looking nose. It's tricky, and it's certainly something that should never be attempted by anybody who's other than somebody who's a really expert injector of the nose. Because, first of all, because it's tricky to do technically, but also because these are the most dangerous noses. These post-surgical noses, the anatomy is different, the skin perfusion is less, and so the risk of ischemia or worse is considerably higher. So these are for experts only, but it really, the results can be really spectacular. So is everybody a good candidate for this procedure? Obviously not. Not everybody is a good candidate for filler in the nose. People need, these people need either reduction or surgical straightening, or as in the third picture, you really can't project that nose enough with fillers. You really need something much firmer than what we have. In the fourth picture, in order to make her nose straight, she needs reduction, because in order to make her nose straight, you would have to lift that radix much too high and she would have a Roman nose. So not everybody's a candidate, but for people who are good candidates, this is a great procedure. So here's the danger, and this is my patient. This is my complication from a long time ago, but this is the danger of post-rhinoplasty noses. This patient had 4 rhinoplasties in the past, and so I tried to be a hero and put too much in her tip. I was trying to sharpen a blunted tip. And because her blood supply to the skin was quite tenuous from surgery, she got compartment syndrome necrosis. I was using calcium hydroxyapatite, so I couldn't reverse it. And this is still fairly early in my career doing noses. And so I'm considered more conservative now in terms of how much I use and the speed at which I go, and and I'm much better at recognizing early signs of ischemia than I was then, I think. So I very rarely use calcium hydroxyapatite with post-rhinoplasty noses for this reason. And just, this is something that certainly can happen. And I've developed a good sort of a very thorough protocol for complications or for impending complications that I've used many times now when I see just the early signs of ischemia. It's really, I think, rescued me from having that ischemia progress into necrosis. So the tip, the columella, and the ala are the most dangerous places to inject. The blood supply is the least redundant, especially postoperatively. And the data I gathered on my non-surgical rhinoplasty results reflects this. So this year, I published a 10-year retrospective analysis of my non-surgical rhinoplasty procedures in the Journal for the Facial Plastic Surgery and Aesthetic Medicine. The complication rate, the adverse event rate, was significantly higher for post-rhinoplasty patients, as you would expect, but it really was borne out in the numbers. Patients who had both voluma and radius used, also the complication rate was considerably higher. It was between 7.4% for virgin noses, 10.8% for post-rhinoplasty noses. But when you talk about, when I'm under AEs, I included prolonged erythema, tenderness, prolonged bruising, all that kind of stuff. So I was fairly conservative in terms of what I counted as AEs. The combination of voluma and calcium hydroxyapatite, or HA and calcium hydroxyapatite, causing more AEs, I think that was because the only time I did that was when the HA filler couldn't lift high enough. And so these were particularly aggressive injections of particularly difficult cases where I was using more filler than usual. So that's why I think the complication rate was higher. There were 5 instances of necrosis during this period of time. 4 of them were patients who had undergone previous surgical rhinoplasty. 3 resolved completely, and 2 had some scarring, one of which you guys just saw. So, that's the retrospective study. As you guys can imagine, retrospective studies are inherently somewhat problematic because data gathering is not going from the chart. It's not necessarily capturing everything you can possibly capture. So to that end, what I'm doing now is a prospective study on non-surgical rhinoplasty, and this is some preliminary data from what I'm doing. And you're the first people to see this data. My God, I had this done just for this meeting. So far we have 110 patients at 1 month and 70 patients at 6 months. The first graph on the left top you see is injection site reactions or adverse events. So at 3 days, you see it which is in blue, at 1 month, which is in orange, and at 6 months, which is in gray. And you can see that if you measure both erythema, redness, every swelling, tenderness, and bruising, it's very rare to see anything but erythema at the tip at 1 and 6 months. Everything pretty much goes away. And that's, erythema at the tip is something that we can fix with sort of vascular laser, or, that kind of thing we can manage that, or patients can cover it up. And usually it's worth it, even if they have a little bit of redness in the tip for a while. No serious AEs, no ischemia, no necrosis. And so percent of patients that experienced injection site reactions goes from 74 at day 3 to 19% and 16%. So next slide, this is what we wanted to also collect is patient-reported outcomes. And so this, oh gosh, okay, thank you. So this is the PROs, shows that vast majority of patients are very much improved, both by their ratings as well as the investigator ratings. And the patient satisfaction with specific aspect of aesthetic of their nose was quite high at 6 months. So far, general satisfaction is really pretty excellent. And so I'm going to take it out to 12 months and see how it goes. There have been 5 reviews of blindness cases published in the last year. They all concluded the same thing: the nose is the riskiest place, especially at the radix and the glabella, which makes sense because this is the closest and most direct route to the eye. Dorsal nasal supratrochlear arteries are right there. These are the branches to the ophthalmic artery, and they're the highways to the central retinal artery. All it takes is 0.1 cc's of material to fill up the arteries from the glabella to the eye. And so the precautions that I take, I'm using BD syringes and I'm injecting 0.01 cc to 0.04 cc's at a time, very, very tiny amounts. So not enough to fill up that entire space, and so if I'm in the wrong, even if I'm inside a vessel, it's a very tiny amount. Voluma flows easily, so I don't have to generate a lot of pressure. I can be very gentle in my injections, and so that way I can go on. I can stay underneath the systolic blood pressure even in those small vessels. And I don't send emboli over, and I can't go against the flow of blood to send things backwards. I inject slowly. Inject slowly, and also very, very importantly, my needle is always in motion when filler is flowing. It also gives me time to react if I see ischemia. And the assistant, that hand next to it, is the critical second set of eyes. If I'm concentrating the aesthetics, they can at least look at the skin and see if there's any kind of dusky spot brewing. So, oops, hang on one second. Let me just go back a little bit. There we go. So what happens? So if I see something happening, what do? Massage, hot compress, aspirin. I check the capillary refill. If I see that it's really quite serious, I'll do Hylenex, nitro paste. I'll always do if I'm consider that this is a possibility of evolving ischemia and necrosis, I will do Medrol dose pack, and that I think has been very critical in saving some of the situations that I've encountered, and hopefully it doesn't get to hyperbaric oxygen and etc. So that's what I have. And in the questions, if you'd like, I can talk about one of the things that I didn't mention here is aspiration. I don't aspirate. I don't believe that aspiration is a good safety maneuver, and we can talk about that in the Q&A. But anyway, so I'm happy to take any questions afterwards, and also offline. You can get in touch with me anytime at Dr. Rifkin or Westside Aesthetics on Instagram, or call me. If there's a bad situation that you're having, I'm happy to consult. I'll also be putting out educational webinars on Instagram. So go ahead and if you follow us, you can see those. So thanks very much.
Thank you so much, Dr. Rifkin. So we'll go to the Q&A, but before we go to the Q&A, I'm just going to summarize because those two talks were fantastic, and it's the use of threads, particularly for the nasal tip, along with the use of dermal fillers to provide contouring and structure to the nose, as opposed to just filling, the nose is the way forward. We know that the major blood vessels of the nose lie in the superficial fatty layer, so the SMAS layer of the nose, and therefore it's really important where your cannula is and where your needle is. I know we have a question on cannulas, and I'll let you answer that, Dr. Rivkin, before I go to the thread question. So Dr. Rinchi Norbu from Siliguri is asking, will injecting fillers with a cannula make it safer so far as avoiding blindness or embolism?
I mean, I think it's an interesting question, and it's something that really a lot of people are talking about with non-surgical rhinoplasty. Theoretically, that's the case. Certainly, if it's it would have to be a larger cannula. It would have to be 25 gauge or bigger, because cannulas that are smaller than the 27 gauge, I consider to be essentially the same risk as needles. And we've seen blindness in other areas caused by, in a situation where people were injecting with a cannula. So I don't think it's entirely protective. The problem is, I think, is that cannulas, you sacrifice some measure of precision when you're using cannulas. Now, some people are very, very good with cannulas, and their results are very good. In my hands, needles are more precise, and I can just do more and be more versatile with the little, really tiny, tiny needles that I use. And also I can really, be injecting very, very tiny amounts. Which also, I'm always concerned. To my mind, it's what keeps you safe is amount, how much you're injecting, the pressure you're injecting it at, and and whether you're moving or not. Because if you're moving, that means if you're in a bad place or out of that bad place, whatever. Those are the three main things that really keep you safe. And so, for me, those little tiny syringes and needles, they meet all of those requirements.
Yeah, and I'll just add to that. So obviously the radix bit and the celion here is a concavity. And so if you are using a cannula from the tip that's going up, often because it's a concavity, you can end up with the cannula going into the superficial plane, which is the superficial fatty layer where the blood vessels are lying. So I think a lot of experts prefer using, particularly in this area, the first point of your, if you believe in a 3-point or a 4-point rhino, the first point would be needle bevel down on the bone, and you can feel the periosteum, and using all the tips you recommended, low extrusion force, decanting into an insulin syringe, very low volume, small aliquots, and sometimes digital pressure on the supraorbital vessels. And certainly as you move down the dorsum of the nose, tenting, because this skin is more mobile. And so actually lifting up the superficial SMAS, the fatty layer, so that your tip is then lying below that over the perichondrium, I find is an additional safety tool. I'm going to ask Dr. Hosaksa to ask you the next couple of questions so that he's interacting.
Thank you, Dr. Chattoshai. Thank you, Dr. Lipkin and Shulamaniza. And there are a bunch of questions from the audience I'd like to invite. And this is for Dr. Shulamaniza. What kind of threads do you use? So, yeah. Could you address this question?
You are asking about the brand of the threads or material?
Yeah, both of them. Could you explain comprehensively?
I used many different type of threads. I think all that are now existed in the market, but I can't use others. I use only Aptos threads because my father invented thread lifting, and we have our own company which produce threads. They are FDA approved, and they are very nice for the nose reshaping. We have special thread for this. But you can use any different type of thread, even PDO, how you want. I showed the method of using of this thread. Of course, it's very important to understand that for this method, it's better to use universal thread with opposite direction barbs, because if the barb is one side direction, it will not hold with the same idea, with the same tension, and with the same result. So you can use any other thread, but idea is thread grafting.
Could
Okay,
I just
there.
ask you about the risk of infection? Because in the literature, and whether it's Aptos or whether it's PDO, and I know your series was amazing with very low infection rate, but there is a risk of extrusion of the threads and infection. And how do you time it? Because a lot of people use fillers along with the thread. So how would you time it, and how would you minimize this risk of infection or extrusion?
Exactly. The prevention is the main thing in this case, because in all cases of infection, I saw that the first was conturation and then infection. So if the thread is very near to the skin, if it creates conturation or it's very near to the mucosa, very superficial, I mean, in time it penetrates skin or it penetrates mucosa. Patient is not feeling this moment, and then bacteria and infection goes into this hole, maybe very small like entry point, and then it touches to the thread, and then you have infection. In the beginning of this infection, you can remove this part of the thread which is very superficial and give patient antibacterial therapy. But if the process is too late, you should remove all threads. So the main thing to prevent is to touch all places, to see nicely in all places, from inside, from outside. It's also very important to make right asepsis, antisepsis cleaning, of course, with solutions from outside and from inside. It's very important to use sterile gloves and not to touch the thread. And it's very important for the nose, because the area is very small. And around the nose, we have a lot of bacteria. And even now, especially now with COVID problems, we all are wearing the mask. And under the mask, we have a lot of bacteria. So I'm advising patient to use during first 2-3 days until the entry point will close, use this mask under the nose, or try to stay in open air, not to use the mask, or at home. So this is also the new problem that I see with infection.
I had a comment to make, Sabrina, especially to Dr. Hosiok. And Dr. Hosiok is actually the current secretary of the APSOPRS. And he was wondering whether this would be a great meeting for him, because he does not do the lips and the nose at this moment in time. The thing is, there are techniques that we will learn from a multi-speciality audience or multi-speciality teachers that we can implement into our subspecialties as well. So I started using threads first for the face, then we started using it for the nose, and my talk's just coming up. And then after that, we started using it in the under eye area as well. So now we use PDO threads in youth in order to tighten the, sort of do a non-surgical lateral tarsal strip, if you will. So it's amazing once we start realizing how things can work in other parts of the face, how we can implement them in our subspecialties as well. Dr. Hosiok, could you have one more question, please? You are way past midnight and you've stayed with us for so long. So in Korea, so would you please ask one more question, please, to the panelists?
Okay, actually, I have many questions to ask, but I found a very interesting question from Dr. Gomez, Stockholm, for Dr. Lipkin. And when you harmonize the nose with fillers, can you combine with a touch of Botox to avoid the movement? And does that way prolong the effect? Could you address this?
Yeah, thanks. That's a great question. I do use Botox relatively in any of the toxins, relatively commonly to lift the tip, as well as to control any kind of flare in the nostrils. This is a technique that unfortunately can't work terribly well for if you have a broad nose. Although it's interesting, because I'll get people who come in and say, "Hey, look, I have a broad nose. Is there anything that you can do non-surgically to make my nose more elegant?" Asian patients, African American patients, that kind of thing. And one of the things I can offer them as well, if we do Botox on the potentially in the ala, that we can get a little bit of less flaring and perhaps a little bit more narrowing. The other thing is, and this is a concept in terms of harmony. When you use the word harmony, I think that's a really important word to use in this within non-surgical rhinoplasty. It truly, everything you do in any injection that you do and any of the surgery, as well as but anything that you do in one area affects the other areas as well. And so if you have a nose, for example, that's broad, you may not be able to decrease here non-surgically a lot. I mean, you can do a little bit of Botox, but what you can do is potentially lift the tip. If you have a bump, you can't make it smaller non-surgically, but you can enhance above and below the bump. If you have, if you have a twist, you can't shave it down. You can't shave bone down, but you can kind of enhance little areas on the sides or little areas next to it, and camouflage. And I think being aware of that, of how these aesthetics, the interplay of these aesthetic areas, I think is really important for success with this procedure, and as it is with other aesthetic procedures in the face, but especially in the nose because it's such a critical central feature.
I think that Dr. Rivkin is absolutely an artist and a physician. When you hear him speak, you hear the words of a true artist. Wanted to thank both of you for wonderful talks, Konstantin and Sasha. Thank you so much. And thank you, Sabrina, for chairing this session. I think that every single one of these sessions could go on for hours because we have so many questions that it's hard to get to them all. But we will need to move on to the surgical rhinoplasty session. And so I'd like to introduce Dr. Ryan Diepenbrock, who is going to be the chair of this session. Ryan is an oromaxillofacial surgeon in the Midwest United States who recently transitioned from his military career. And he's also the recent president of the American Board of Facial Cosmetic Surgery. And just great to have you here, Ryan. Thank you so much. And we'll hand it over to you to lead the rhinoplasty section forward.
Hey, thank you guys so much for having me. Really, truly an honor. I've known Dr. Nakra for quite some time, and I was very excited when he gave me the opportunity to do this. This rhinoplasty is hands down my favorite surgical procedure. And I think that a lot of that has to do with what we've talked about so much already, is the art behind it. So, to have the honor to chair this section of the Global Cosmetic Surgery Master Session on lips and noses, again, I just want to thank Dr. Nakra and Dr. Shom for doing that. I think that rhinoplasties, like I said, are the most challenging, require the most artistic variation. And it's really like art. I mean, you could give 5 different surgeons the same paint and the same canvas, and you're going to end up with 5 different photos, which I think is really neat. And that's why it's so important, when you're having your discussion with your patients, to understand and really give them plenty of before and after photos so they can see the type of surgery and the type of work and the type of art that you do, because mine's going to be different than everybody else's here. And it's also ever changing and ever evolving. I mean, I think there's so much trends in society that also kind of work their way into rhinoplasties. There's so many trends with what is considered beauty at this point in time. So very cool. I'm very excited to listen to our 3 speakers today. We're gonna, first off, I'll introduce them. We have Dr. Mike Nyack, who's really, internationally renowned and famous cosmetic surgeon from St. Louis. And he was educated at Harvard and Yale, Washington University. He's been a keynote speaker all over the world. He's known on social media as the nose ninja. And, to be honest with you, he's one of the guys that I personally follow and look into and watch his videos and read and see how he does things. And so he's been a large inspiration in my surgical practice, both rhinoplasties as well as facelifts. So I'm excited to hear Dr. Nyack talk. Again, then we have Dr. Shom, who's the co-founder of this organization. He's a renowned surgeon, author, lecturer, and philanthropist. In addition to his surgical acumen, Dr. Shom recognizes the contributions of multiple specialties in regards to facial cosmetic surgery. He's been very integral in harnessing these skills and techniques of all the different specialties. So that's one of the great things about this organization is you have people with multiple backgrounds who you can learn from. He's going to be speaking today on rhinoplasty surgery versus filler. And finally, our third speaker is Dr. Basser. So for the past 30 years, he's been one of India's leading authorities in rhinoplasty and facial plastic surgery, co-founder or the founding secretary of the Indian Society of Facial Plastic and Reconstructive Surgery. He's written 3 textbooks on rhinoplasty surgery, and he's been instrumental in educating over 1,200 surgeons from multiple specialties. Dr. Basser will be discussing the management and techniques of nasal tip surgery. So again, I think we got a great lineup, and I'm excited to do this. Please leave any comments or questions that you have, and we'll get to them, and hopefully we can answer everybody's questions. And I think we're going to start off. We do have our moderators today, Dr. Pragnathi Shubha and Nirmaya Thapa. They'll be helping with moderating and answering questions. Welcome to you, and let's get started with Dr. Shom.
The audio playback's not working there.
You'll have to use that, Monica. You'll have to start that again. Reshare it, please. Stop the share and reshare it, please. Hello, everyone. My name is Dr. Debraj Shom, and I currently run the aesthetic clinics in India. The aesthetic clinics has multiple centers in multiple cities all over India. It is important to declare my financial disclosures. I am a faculty with the Allergan Medical Institute and for MERS, which uses or makes the products which have been used in this particular presentation for the past 15 years. Now, rhinoplasty as we know it is very, very important. And as in this young lady who underwent a pen bomb blast injury, you can have the necessity for multiple fractures to be repaired in the face. And then you have to perform an external rhinoplasty for something as complex as this. And therefore, having surgical skills is very important. Now, in this particular lady, you can sort of see the transformation that was created by multiple surgeries which were performed. And you can see we can give her a new lease of life. So I think there are advantages of knowing surgical rhinoplasty. However, we also, as surgeons, we also have to be aware of the fact that there are more and more people who want repeatable, predictable procedures with zero risk. And surgery, as we know, in the best of hands, can have complications. Therefore, the non-surgical nasal rejuvenation is something that is gaining more and more precedence and preference amongst patients. So a non-surgical nasal rejuvenation is one in which we perform a medical procedure with fillers and with threads in order to fill in the depressed areas, lift the angle of the tip, or smoothen the appearance of bumps on the bridge. Now, initially when we started non-surgical nasal rejuvenation, approximately 5 to 6 years ago, we believed that it was an augmentation procedure. So we believed it could not reduce the size of someone's nose. Obviously, you were putting in fillers, so you were adding material. How then could you do a reduction rhinoplasty? But the truth of the matter is, fillers, when used creatively, can actually appear like permanent makeup and can make noses appear, noses can be made to appear thinner using a combination of fillers and threads. And that's what my presentation is all about. However, there are certain cons, obviously. So it helps if you're a surgeon, especially in the thick skin, which is seen in the South Asian and Asian Indian population. It becomes very difficult to really give decent definition with fillers. Results are better in thinner Caucasian skin. And obviously, the biggest con of using fillers is that even though it's a small 15-minute procedure, it will need repetition every 18 months or so. So our choice of filler typically is the Juvederm Voluma. I like it for its high G prime. I also like it for its fact that it causes a great lifting, it has a great lifting capacity, and it provides good structure. We inject it with a cannula, not a needle, and we'll talk about the blood supply of the nose, which can be very tricky. Anesthetize the nose with prilocaine jelly, which 45 minutes prior to the procedure, and then we perform it in the doctor's office, so this is not done under general anesthesia. The con obviously is it cannot address every type of nasal issue, so surgical rhinoplasty skills are a bonus, of course. And that's the nasal vascular anatomy, and you should understand that most of these blood vessels of the external and the internal carotid actually go ahead and can cause blindness, and therefore one needs to be very, very, very alert while injecting fillers as well. That's how the fillers are injected. Typically, an entry is made with a 21 gauge needle, and that's a 22 gauge cannula which is being used. And we are sort of passing it just supraperiosteally below the nasal mass, and we are laying out the filler just and molding it with the other hand. So the non-dominant hand is sort of molding it. You can also do it from the top, especially for people who have a depressed or a very obtuse nasofrontal angle. It makes it easy to inject it from the top and thereby go ahead and make the nose appear much more symmetrical and structured. There are also possibilities of injecting it in between the lower lateral cartilages and into the septum, and that way you can actually cause the tip to go up. And by getting the tip to go up, you can actually reduce some of the other problems which are there with a dependent nasal tip, especially one which gets accentuated when someone smiles. These are some of our patients, befores and afters, and I'm very cognizant of time, and I've got 10 minutes, and there's so much to say. But a quick round of befores and afters, so you can see how in this particular patient, the nasal bridge now appears much more defined and shows a far better reflection of light. Ultimately, fillers are like permanent makeup, and that's the sort of definition that you can create. Also, when you look at the basal view, you can see that almost horizontal or round nostrils have now been converted into slightly oval or vertically oval nostrils. So you've been able to pull the bridge up in that sense. It's another patient of mine who came in from another surgery, and she actually has a very big prenasal scar. And in patients like these, obviously performing a flap is something that we could do, but it's a complicated procedure. And what she wanted was actually a little bit of filler. After you've done the filler, you can actually find that the nasal scar actually shrinks in size. So you can see how it's become smaller here. And that's because the nose here overall has become better defined, allowing the skin some leeway over the bone and therefore allowing it to contract back into position. She was pretty happy with the results. That's another patient of ours who's had just a nasal filler rhinoplasty, and those are the befores and the afters immediately after. So you can actually see the injection marks which have been left on the nose. Nasal thread lift involves the putting in of cork threads on the nose. And I know that my colleague Constantine has already talked about this as well. But basically, nasal cork threads have corks all the way around, which sort of engage the mass and the nasal skin and tend to pull it upwards. That's how the nasal threads are being put in, and that's a 19 gauge cork thread which is being inserted both from the lower part of the nose near the tip as well as near the top of the nose at the nasofrontal angle. And that's the procedure. This is a slightly painful procedure, and obviously bless our patient for being so appearing to be so comfortable. But as you can tell, even with the prilocaine and the nerve blocks, the patient does feel this a little bit. But this really adds structure to the nose and causes the nose to appear much tighter and far better than just with the fillers. Now that's our patient, and you can see how her nose looks much narrower. And you can also see how the central dorsum of the nose now has a much better reflection of light. That's the side view, and you can see how the nose looks far better on the side view as opposed to before. That's another profile view. That's the base view. And again, you can see the nostrils, which were more circular, starting to become elliptical. We can also use the non-surgical rhinoplasty for the small humps, as in this patient. You can see how the hump has been layered with the presence of fillers, and then we've also used the cork threads in order to tighten the nose better. Now, some patients will have a drooping nasal tip. So you can see how this patient has a drooping nasal tip, which has been treated with fillers both through the dorsum, then also the fillers to the columella, fillers to the pyriform fossa to sort of raise the pillars or raise the base of the nose, and then threads on the dorsum as well. And you can see the difference that this ends up creating. When the patient is trying to smile before, you can see how the angle was between the nose and the lip. And now you can see how the angle is, even when the patient is smiling, the tip is not drooping down, and that's a non-surgical rhinoplasty. You can also use non-surgical rhinoplasty in other creative ways. So that's a patient of ours who had a very flat nasal dorsum. She came in for a rhinoplasty. You can see how the nostrils are almost horizontal. And in this particular patient, we performed a surgical rhinoplasty. But post the surgical rhinoplasty, whenever she put her hand on this particular dorsum, she would say that it's not as smooth as before, which can happen sometimes post-surgery. We decided to layer the top with a little bit of filler. That's how we've done the filler. This is immediately post the filler, so you can see the bleeding points. And that's how the nose now looks. You can see the external rhinoplasty scar below on the columella, but you can see how the nostrils have become vertically elliptical. So you can use it for a small touch-up post-rhinoplasty surgery as well, instead of going in for another surgery. So in summary, it's a good tool to have, and it's something that everyone should know what to do. But obviously, if you have surgical skills, then you can titrate better, because everything cannot be achieved just by fillers and threads in the nose. And then obviously there are different types of nose. You need to take a systematic diagnostic approach and treat every patient in an individualized manner. We love teaching, and that's one of our training courses just coming up. It's a fellowship in facial aesthetics that we perform at the aesthetic clinics. And we encourage everyone to come and learn some of these skills. And we have dedicated ourselves to a lifetime of teaching. And we hope that there will be more people who will take advantage of our courses. I needed to take a minute to talk about one of the sponsors for today's meeting. The sponsor for today's meeting is the QR678 Neo. And as some of you may be aware, this is a formulation derived from a plant base. It's a combination of 6 growth factors and has biomimetic peptides. I was one of the founding team which led to the development of this revolutionary hair formulation. This is administered via mesotherapy to the scalp. There have been 10+ clinical trials demonstrating efficacy in various hair conditions, which have been published in high impact factor peer-reviewed international journals. Interestingly, in a head-to-head trial, a randomized controlled trial, this was 300% more effective than PRP. This works really well post-hair transplant as well. And this year was a proud moment for us when the QR678 was highlighted as one of the top innovations in IMCAS 2021 and the 5cc Congress. Obviously, this is now being utilized in 10+ countries at the top skin and hair clinics and with key opinion leaders in these countries. This is also FDA approved in the countries that we are talking about. So thanks to the QR678 team for giving us an educational grant for running this particular educational program. This is a book that we would recommend and request everyone to read. And this is also something which will be given in the gift hampers for the early bird registrations for this particular Congress. This is an anthology which consists of short stories about the doctor-patient relationship. And as doctors, we sometimes face a really tough challenge talking to patients. And there are even instances of violence, physical as well as otherwise, against doctors in various parts of the world. And if you are short on inspiration and you would like to get inspired, read about these 25 doctors in this particular anthology, which has been put together by myself and Dr. Aparna, which talks about all the wonderful things that doctors end up doing and how they are trying to give the human race greater life and energy, especially in this COVID pandemic. I thank you for your kind attention, and thank you once again for having us in between all of you and trying to spread education. Hopefully this talk was interesting for you all. Thank you.
Ryan, you're on mute. Yeah. Take 2.
Oh, I was just saying, hey, thank you. That was a great talk. I have a couple questions myself, but I think we want to hold those off till the last 10 minutes, right?
Yes, please.
Perfect. So next we have Dr. Basar, who's going to talk about tip rhinoplasty.
Hi, I'm Dr. Brajendra Basir, rhinoplasty surgeon at the Akash Hospital, Indore, and Jaslok Hospital, Mumbai. Today, I'll be talking to you about nasal tip plasty. These are my places where I do my most of my rhinoplasty work. While I'm in Bombay, I operate at Jaslok Hospital and Bhatia Hospital. At Indore, I got my own hospital, Akash Hospital. Now we talk about different types of nasal tip surgery. The most common in flavor these days is primary cosmetic nasal tip plasty, and that you see in fashion magazine. And people talk about terminology like tip diamond, supra tip break, and bifid lighter flex. So let's talk about each one differently. And first is primary cosmetic rhinoplasty. This is a patient who feels her nose is broad, the ala are white, and tip is lacking projection. And she wants an improvement in the dorsal height. She wants a correction of white flaring ala, and she wants a better definition for her nasal tip. Now, for this kind of patient, the dermal creation sutures, dermal equalization sutures, and interdermal sutures. So we use them for improving the tip definition, so that we produce a tip which is better looking and have a perfect distance appearance. Now we need to augment the dorsum as well proportionately, because no rhinoplasty is in isolation tip plasty or dorsum. And here is the patients about 3 months later, and you can see how the dorsal aesthetic lines has been formed. The tip definition has been improved, and you can see how the light reflex shows the tip diamonds. There is a slight rotation of the tip as well, and the tip angle, nasal labial angle and tip angle both has been improved, and she's very pleased with the results. And you can see how these rotation tip angles. But the word of caution, these kind of things are only possible if the skin condition permit, and this is not this is a basal view which shows in the slight increase in the tip height and reduction in tip base. We also did alar based resection in this case. Now we come to the second type of tip problem, which is under projected nasal tip. Now this is requires a special planning, and here is a young girl who had a tip which is severely under projected and white flaring ala, and she had a lot of psychological problem and social issues because of it. Now the surgical approach is to have an open rhinoplasty exposure. You can have a stair step incision or inverted V incision, and this is how we expose the septum to harvest a graft which will be used as a septal extension graft. This is septal cartilage graft which has been harvested, and so you preserve the dorsal and collar strap, so that preserve support. Both the alar cartilage have been separated from the vestibular skin, because we want to make a new tip which is more anteriorly, and we use a hockey stick type of caudal septal extension graft, so that this can be secured in position. This is the septal extension graft which will be used to support the this is a framework which support the nasal tip. It's very important development and one of the few real significant improvement in the rhinoplasty techniques. So this is how the septal extension graft is fixed with the L frame which we have left, and these are the alar cartilage which are fixed over the septal extension graft, and we'll be making new domes in a new position to improve the tips. Now these are alar batten grafts on both the sides, so that the ala are well supported in the alar regions, and we are able to improve out the tip definition and have a better control of the nasal tip. These are alar extension graft which are taken from the septal cartilage graft on both the sides, and this is because we do not want to take any onlay graft on the cartilage, because which may be visible through the skin. And this is dorsal augmentation, and caudal margin of the lateral cobra should be positioned symmetrically to minimize the chance of the exposure of the nostrils. And this is the final closure. The tip definition has improved, and tip length is also improved. All grafts in this case were buried inside the nasal tip framework. No onlay graft or diast cartilage for camouflaging anything, because skin is thin and these may be visible. Now these results by this techniques are stable, and you can see out the pictures 1 year after. You can see out the nose has improved in all the directions. There is the tip definition has genuinely improved, tip projection has improved, nasolabial angle, nasal tip angle, everything has been, nose looks more proportionate, and she is very, very pleased because with the results, because she has always been teased with this thing. Now there are no onlay grafts which have been used, so that there are no chances of visibility of the graft, so the skin and long form is not there, and these are results at 1 year, and we expect them to be stable results in long terms. So very young girl, very pleased with the results. And the columella, the width is also narrowed. Now we go to another type of nasal tip deformity, and this is wide and deformed nasal tip, and this also requires special planning. And in all the tip plasty, the skin is the factor, the key factor which decides the technique and the results. So here, this is a girl with a very peculiar type of skin. There's hardly any subcutaneous tissue. This all the skin is so, it's like a parchment like. So we again, in this case, we cannot have any kind of visible onlay grafts to camouflage to use it. Now just like in last case, we harvested septal cartilage and we used it as L-shaped septal extension graft, and this graft will be buried inside the framework of the nasal tip, but it provides a very strong support to the tip. As I said, we have to use all the grafts which are visible or which are buried, invisible or which are buried inside. So this is the subluxation graft which is projecting above the dam, because we have the task of increasing the tip projection. At the same time, we have to give a better definition to the tip. Now on this firm subluxation graft, the two medial crura are sutured on of it, and when we do a lateral crural steel to camouflage the subluxation graft, and these are alar batten graft, they will be used inside, they will be buried inside the upper margin of the alar cartilage, and these are the results. You can see out 2 years post-operatively. She is a doctor by profession and is very pleased with the results, and you can see on the table result and results at 2 years. Improvement in nasal tip projection and rotation, both are improved, no visible graft marks, and in spite of having this such kind of a skin which is very difficult to deal with, any kind of diast cartilage, morselized cartilage, or any type of masking things, fillers like you use, can be visible on these things. So 2 years later, and results are maintained and stable by this technique. So these skin conditions, especially in our conditions, it decides the type of technique which you use. Now come to another problem: over projected nozzle tip. Those are under projected. How to put this? This can be a difficult task, and you need to reduce the nose and all these things to reduce the tip projection. So this is a very prominent alar cartilage, very wide cartilages. So first thing is we do a kyphelectomy. Now there is depends on sometimes we do out kyphelic infold, but in this case the cartilage are very prominent form, so we do the kyphelectomy. And now we are the alar cartilage has been separated from the vestibular skin, and you can see how the tip has been set back. It has been sutured on the medial crest is sutured over the lateral part, so that we are reducing about 3 to 4 millimeter of tip. And this is after the tip projection has been reduced, and few months later, and you can see out the over projected tip has been set back. And here again, we are not using any kind of graft, and you can see out that the projection has significantly improved and well maintained. And most of these patients come from IT industry. See out in profile view, you can appreciate better how the tip has been set back. Now these are very delicate techniques, and you need to plan it out very carefully, the amount of setback you want to do it out, because doing it, overdoing or underdoing can be catastrophic. And as I was saying, these are all from patients from IT industries, very well educated, well understand about the disease. Let's see out in the follow view. And so the over projected nose has been reduced proportionately. Now comes the difficult situations. Now, these are the unfortunate patients born with the congenital deformities like binder syndromes, cleft lip nose, and when it has been revision rhinoplasty. Now, case of binder syndrome, here there is hardly any columnar projections. The columella is not well developed, and here you need to do a structural rhinoplasty, take out rib cartilage, septal extension graft, increase the width of the length of the alar cartilages, and make new domes. And these are the table results on the table. This is a long surgery taking many hours, but these are very the patients are very happy with the results, because most of these congenital deformity patients have been recalled all their life, and the result at 1 year post-op. You see out the columnar length is because we have not done any VY plasty, and this is, you can see out in a 3/4 view that the projection has been improved significantly. Of course, she also had a dorsal augmentation. So 1 year later, these results are very happy patients. She's also from medical profession and very pleased with the results. We have a large series of binders, and the result, you need to use a variety of techniques in binder syndrome, depends on the grade and severity of deformity. Then comes the cleft lip nose. All the unilateral cleft lip noses, they always have alar deformity, which is on the, you can see out like in this case, the alar has been on the lower side. So we have dissected out the alar cartilage from the vestibular skin very carefully, and use a rib cartilage to support the tip, and use on the fascia graft on the cleft side, and you can see results at 8 months. Now these are for cleft lip nose, very good results, and the patient is very pleased with the results. And as I said, most of this patient with congenital deformity, even though she was not expecting as much of improvement in these cases, but by careful planning and use of graft to support the tip, there are various ways of doing it out, but this is the way we are doing this cleft lip nose, and we have a large series of cleft lip noses, and occasionally we have to just are improving. Now what happens when somebody has done a nose job and does severely damage this tip? So these are increasingly common, because we are getting a large number of young surgeons who are trying to do out things. Now in this case, you see the alar cartilage is severely deformed, the medial crest is almost absent, so we have to make the medial crest with the strip of rib cartilage, and make up for the damaged alar button graft is used to make up for this damaged rib cartilage. And these are the results on table. This is again septal extension grafts, alar button graft, the medial crest which has been made neo medial crest, and see the 6 months follow. The damaged tip has been surgically damaged tip has been improved. The tip projection has been improved, and this can be one of the very difficult challenging cases in rhinoplasty, to improve the definition of these kind of a damaged tip, making a new nasal tip. And dorsal lines are visible. Dorsal reflex has been significantly improved. See out again in the lateral view, the improvement in the tip definition and projection, and the nasal tip angle and nasal level angle. Basal view, alar concave and tip definition both have been improved. We used alar rim graft also in this case, and this patient, he traveled a long way for these things. The rhinoplasty goals are now changing. Initially we said that you are better than before. No, that's not enough. Now our goals are changing. We are trying to achieve near perfection, and so out you should be working hard to do out. You may be used to winning in general, but if you want to play in Champions Leagues, you need to be more focused, and need to be more giving details to the minor details. After 30 years rhinoplasty, I still feel that I am a student and learning. Learning is everyday's procedure, and all your life, probably this life is short even to master rhinoplasty. These are my books on rhinoplasty.
All right, great lecture. Is Dr. Bosser is not currently with us, right?
I believe that's correct. Yeah, he was not able to make it, so we can, I'm sure that the panel will be able to answer questions about tipoplasty if there are any, but we could probably move on to Mike.
Perfect. All right, last speaker for this section is Dr. Mike Nyack, AKA Nose Ninja, AKA Neck by Nyack, AKA social media sensation and COVID expert. So it's quite an honor to have him talk to us about the 10 things that he learned. Just a brief story, I met Dr. Nyack on a personal basis probably 6-7 years ago, and we were on our way to the AACS meeting. And one thing that he asked me was, what have you done to change your practice? What have you learned in the past year? And it's funny because every year when we see each other, I always ask him that same question. I think it's great. And what it does is it shows that even, someone with his status and his expertise is still constantly learning. And I think that's important for all of us, being continuously learning, being continued students and learning from our colleagues from multiple specialties, which I think is, such a fantastic aspect of the society and the AACS. So without further ado, we'll give you Dr. Nyack.
Thank you very much, everybody, for having me. I'm going to share my screen here. It was a very nice introduction. And I still cough when I talk once in a while. I got a case of breakthrough COVID after vaccination. So it was about a week ago. I feel fine, but I may have to clear my throat here and there. So let's share screens here. This was actually a perfect presentation to start with right before mine, because a lot of what Dr. Basir presented, which I think was excellent, are things that I used to do more frequently and still do on occasion. But I can see if I can make this window get out of my way here. But I've kind of moved on from it a little bit. And so I think we all have room to evolve as we practice. And this presentation is, they used to say 10 things, but it's just a bunch of things that I've changed over the last 5 years. So disclosures wise, the relevant disclosure, I'm on some boards for injectable companies, none of which matter for this, but I do have a video series, one on facial surgery, aging face surgery, and one on rhinoplasty. And all the video clips from this presentation and all the original illustrations for this presentation come from the rhinoplasty series. I always like to at least mention or at least talk about the people who taught me everything I know. And so from a rhinoplasty standpoint, these are the guys. Alvin Glassgold is my fellowship director, and Norm Pastorek's the first guy that showed me you could do rhinoplasty well under just sedation or local. And then I picked up various things from various other people, but special thanks I have to go to a guy I've never met, Barish Sakar. He changed my practice. I mean, his current writings and a lot of his current videos and publications are just revolutionary. And I have to put his Yelp and Real Self reviews up here because it makes me feel better. I think he is the absolute best living rhinoplasty surgeon today, which makes him 3 stars on both Yelp and Real Self. So if that gives you any sense of what those sites are worth in my mind. So about this list, I started practicing in 2004. The changes you're going to see on this list, things that I list, some of them have made surgery go more smoothly and bloodlessly and therefore shorten recovery. Others have been not so much technique as more aesthetic improvements, things that have made, I think, my results prettier than they used to be. Others have been ways to, when you have a lot of cartilage, you feel like a king and you feel all powerful. And when you don't have very much cartilage, you start to feel increasingly impotent. And so it becomes important to find the most efficient ways and maximal ways to use whatever cartilage you're lucky enough to have, and then to plan for rainy days and maybe bank whatever excess cartilage you have. So those are some of the changes and efficiencies I'm going to introduce here. And then the others are just little bits and pieces. And I want to emphasize again, I learned all this from somebody else. Every one of these I can tell you who I picked them up from. These are just little bits that I've added to my practice. So starting with tips that make surgery go more smoothly or more bloodlessly, I started using tranexamic acid. Now it's old news. I think I was the first one in facial cosmetic surgery to use it. I've had it in my tumescent solution and in my rhinoplasty local in the middle of 2017. I remember getting out in front of a group at Vegas saying, anyone heard of tranexamic acid? Raise your hand. And literally no one raised their hand. I was on stage and I said, I promise you 2 years from now, you'll all raise your hand. And so I use it for rhinoplasty. I get now, of course, in OBGYN, orthopedics, oral surgery, it had been used years before. but plastic surgery, it's relatively new. So for rhinoplasty, I take a gram vial of it like this. We get 800 milligrams of it IV, and the remaining 2 cc's is mixed in with my local anesthetic, which ends up becoming a final concentration in the local of 1% TXA. I do think it makes a significant improvement in bleeding and bruising. Not as much as the next thing I'm going to tell you, but I think it helps. There are some case reports of intrathecal administration of TXA creating seizures. So not that any of this is intrathecal, but maybe would you avoid the septum with tranexamic acid injections? You could maybe make the argument to inject the septum without tranexamic acid. Other than that, no complications. This is the big one, subpericondrial dissection. So I used to do what everybody else does, which is just raise the nasal skin soft tissue envelope in the easy plane, which is the sub-SMAS plane, but you can see at the top there, you can see a little blue show through, almost like when you're getting to the right plane of the septum. If you get subpericondrial in the nose, in the external nose, now I'm going to catch that blue area and use blunt dissection and stay on the subpericondrial plane and continue. Number one, it's a bloodless dissection. Number two, since it's bloodless, it doesn't weep as much post-operatively under the flap. So the bruising, I introduced TXA, and then 2 years later, I introduced subpericondrial dissection. And the subpericondrial dissection is by a mile the bigger improvement. So you can see the pericondrial edge right there as I'm chasing down the medial crus. By a mile, the bigger improvement was subpericondrial dissection. Now the trouble is the perichondrium is stronger than the cartilage, so it's difficult to get under the perichondrial plane. You will wreck your first couple lower lateral cartilages trying to get under the subpericondrial plane, so be careful with that. But that has been a game changer. It also makes the cartilage softer and more flexible. So now here we're going to get to the subpericondrial plane in the dorsum. And this is easiest dead midline. It's hard to get to it if you follow from the lower laterals past the sesamoids and try to stay. It's best right there, subpericondrial, dead midline, and then follow that cranially and laterally. When we do this, again, you'd think, does it really matter? It does matter. That perichondrium is one more layer of thickness over a dorsum, which minimizes irregularities. And then both the upper laterals and lower laterals without perichondrium are really pliable. So 5-0 is plenty, 6-0 is sometimes enough in terms of what it takes to bend these sutures. And because if you've ever scored perichondrium, you know it helps this cartilage bend one way or the other. When there's no perichondrium, the resistance is next to zero, and I think it helps reduce long-term relapse. So I think this is the biggest thing of this whole presentation. Well, one of the two biggest things of this whole presentation. And I've had discussions with peers like, it doesn't really matter. I used to think that it matters. So things that improve aesthetics. So again, Beres Shaker, his polygon concept rhinoplasty, I think, is revolutionary. This is a paper. It's readily available online. Excuse me. He's also got a great YouTube video that's literally called Surface Aesthetics and Tip Rhinoplasty. It's like a 14-15 minute YouTube video, completely worth your time. You should watch it. He doesn't explain it very well in the video, so you'll get a better sense of it out of his paper and also from what we can tell you here. But things from this paper are responsible for improvements in the next several slides. So number one is just in the aesthetics. What does a pretty nose look like? So on the left is the traditional nasal aesthetics. You know, what are the angles and what are the rotations and what are the brow tip lines are parallel and the domes are this way. We've all seen noses that meet those criteria and look 100% operated. We've all seen it. We've seen noses that meet every one of those criteria, but you can tell instantly that's not a normal pretty nose. It's a post-surgical nose. And so on the right is the polygon concept aesthetics. And I'm just going to point out a couple of keys. The brow tip lines are not parallel. The brow tip lines have keystone formations to them. The globella's got an upside down kind of pentagon formation to it. There are shapes here that we've never named in normal rhinoplasty before. Space polygons, the infralobular polygon, columellar polygon, interdomal triangle are concave. And we often, in traditional rhinoplasty, look at clefts between the lower laterals and try to eliminate them. We say, here's a cleft, let's kill it. It's important to preserve these spaces. It makes prettier noses. A thing called the facet polygon. That's a piece of vocabulary I never used before. These things really change what a nose looks like. And so I encourage you very strongly to get kind of a little bit involved in this. So again, I think the pieces of this that have changed my life are, number one, that intradermal triangle, columnar polygon, and the other space polygon, infralobular polygon, preserving the openness there, the importance of the facet polygon. And if you look at the dome triangle, the dome itself is narrower at the top and wider towards the alar rim, towards the soft triangle region. The dome is not a rectangle. The dome is a triangle. And that is, again, revolutionary in terms of what the shapes look like when you're done. So tying right into this, I used to make a transcolumnar incision, and I was very quick with this. I'd make a transcolumnar incision, and I could take my little iris scissors or Will's scissor, and just trim right, follow right the caudal margin, make a marginal incision along both sides with my scissors and whip the soft tissue up. Now I make an intracartilaginous incision. I leave a couple, 2 millimeters of the caudal margin of the lower lateral gets left in the flap. And this picture is from that paper. It's better than anyone I could get, so I'm just using it. You can see, I can't point unfortunately, but you can see the little rim of cartilage left in the alar rim. And you can see the whiteness of the perichondrium on the back of the flap. Why is that important? Number one, when you make the intracartilaginous incision, it makes it modestly easier to get in the subperichondrial plane than if you're in a marginal incision. And then two, that little piece of cartilage helps define, accentuate, and support that facet polygon. Secondly, so what we're seeing on this diagram with the lower laterals, you're seeing that auto rim graft cut. Imagine if you took more from that same spot, leaving the vestibular skin. That now is a caudal trim of the lower lateral. So part of it we're leaving in the rim flap. Part of it you can actually take like a cephalic trim, leaving the vestibular skin down. You can take a caudal trim. And why would you care to do that? Because when you have a bulbous tip, it is not just bulbous in the anterior posterior dimension, it's bulbous in the cranial caudal dimension. It's bowed in both axes. And so the traditional answer to that for the cranial caudal is to do a big cephalic trim, okay, to cut. Now, when you think about it though, the top edge is the most curved and the bottom edge is the most curved, and the middle strip, the fillet, if you will, is the flattest section. So it makes a much easier construct to take a little bit off the top and a little off the bottom and leave that inherently more flat portion. And you're doing less cephalic trim. So there's less tendency for that remnant strip to be sucked up into the vacuum of a 9 millimeter cephalic trim or an 8 millimeter cephalic trim. And so this is another critical game changer. I used to take 1/3 of lower lateral crura up off the vestibular skin, just exactly like we saw in the last presentation. It's a very powerful technique. I used it all the time when they were bulbous in those axes. Take them off, back them with alar batten grafts, tack them flat, transpose them into the lobules. I used to do that all the time. This, I'm using the caudal trim and cephalic trim for the cranial caudal arc, and then using tensioning for the anterior posterior arc. Plus the next thing you're gonna see is medial crural overlap, has eliminated 99% that. I almost never take the lower laterals up off the vestibular skin, back them, and transpose them anymore. Almost never. Next up, hemidomal suture. So the hemidomal suture is like any other dome binding suture. The difference is it's only at the cephalic margin. It's not a mattress suture. It's a simple suture. And what that does is, number one, it creates narrower at the cephalic and wider at the caudal margin. It creates a domal triangle instead of a domal rectangle, okay? Number two, because it's only pinching, if you will, at the top edge, it everts the bottom edge. It everts the caudal margin of the lower lateral cartilage. You'll see this in the video I'm going to show you here in a minute. I have a video to show you all these things. So it actually helps open up the caudal edge of the domal triangle, and it improves the resting angle. The resting angle defined between the upper lateral and lower lateral. So it improves the resting angle. It opens the caudal edge of the lower lateral. And it's super easy. Oh my God, it's so much easier than a mattress suture. And if you don't like it, you take it out and redo it. And if you use a tapered suture, you can do it 10 times and the cartilage is still fine. So it sounds crazy. The simple stitch where you go over the top of the dome, and you'll see it in these next couple videos, much better. So here comes a hemidomal suture. So what I've marked there is where I want the dome to form. There's a 5/0 PDS and a taper needle. The first purple mark more medially is the original dome. The next purple mark is that dome I'm trying to form. That's it. That's the whole suture. Now, if you look, you have a domal triangle. We have projection and rotation compared to the other side, triangular dome. And we'll see here in a second, the caudal margin is everted and wants to stay everted. It's too easy. It sounds crazy, but it may. And if you look, you can see that triangle staring right at you. The dome is absolutely triangular. So we talked about how we deal with cranial caudal excess now with the cephalic and caudal trim, and then another piece of the excess is actually used up by that rim graft, the outer rim graft. Now, how about anterior posterior excess? I used to, the overprojected nose that Dr. Basir showed so nicely. I used to raise up the lateral crura and trim off the distal end. Take it off the vestibular skin, trim off the distal end. That's how I dealt with anterior posterior lengthwise excess of the lower lateral, or maybe do a lateral curl flap overlay or something like that. But all those involve interrupting the lateral cruise or elevating the lateral cruise. Well, now this is again all part of the same polygon concept tip. You use that lateral curl steel to tension, to pull the domes more forward, which straightens the lateral cruise by tension, and you're creating excess on the medial cruise. You're driving all that excess to the medial cruise. That's an easy cut overlap sew. So you're driving all of the excess into the medial cruise, leaving a completely intact intermediate dome and lateral cruise. And then that medial cruise construct, that's going to get reinforced to the end of days with Collier-Miller struts and septal extension grafts and sewing them to one another. And so that is the perfect place. If you can introduce a weakness with an interrupted strip, do it there. So that has been revolutionary to me. The other thing about that is if you have a hanging or bowed columella, when you divide there, you can pivot it back so it doesn't bow forward anymore. You can make it, you can retract it if you want to by breaking the bow of that, the inferior bow. When you put it back together, instead of putting it back together at the same angle, you can flatten it or bring it back in. So that has improved that. And then finally, when you do this, then there's no more tension left. It's not like you have tension being held by trying to deproject things and hold them to a septal extension graft. I used to do that. Or this way, you basically make your cut, let the overlap happen passively and tack it together. And now you have a zero tension construct in the end. So this is an example of a tip that I would have previously done with taking up the lower lateral crura, putting backing grafts on there, doing an extensive cephalic trim, transposing the remnant construct into the alar pocket. And you can see both in the shadowed pictures on the left and the flashed pictures on the right, she has nice flat lower lateral crura. They've been really nicely flattened. She has the shadow that you want to see where the upper lateral joins the lower lateral and across the super tip. It's nicely shadowed. She's got tip definition, and there's no pinching at all along the caudal edge of the lower lateral. Why? Because it's not been brought in by a dome binding suture. Only the top edge has been brought together. To me, this is much prettier than I used to be able to create with dome binding sutures, and it's so straightforward. I probably did a 2 millimeter cephalic trim on her because the other 2 millimeters came off the bottom and the other 2 millimeters came into the rim strip. So it's a 6 millimeter difference with a 2 millimeter cephalic trim. All right, next. So those are all soccer stuff. So I thank him for that. Tips to use available cartilage most efficiently and optimize the ease of future revisions. So number one, component dorsal hump production with turn-in flaps. This is not news. A lot of you already know about this. But you rest the hump and then you lower the septum sharply. But critically, and these are diagrams from my video series on the top right there, you want to preserve the entire transverse portion of the upper lateral. That way, the more you take the hump down, the more excess cartilage you have that willfully just wants to fold in as a turn-in flap. So this is an example of a one-sided turn-in flap. What happens is, if you leave that whole piece there, it just wants to turn inward. That's its natural shape. And the bigger the hump reduction you take, the easier that turns in. So the shorter your nasal bones, the longer this middle vault is, the easier that turns in. So short nasal bones and big hump reductions are the two biggest indications for middle vault widening, right? So again, and lastly, if you've been subpericondrial, this flap is easy. It doesn't fight you when you turn it in. So this is an example of someone that I would have previously done a one layer, even double layer spreader graft on this person, right, to get the right side built out. But by taking the dorsum apart completely, now it's easier to shift the dorsum and the two side walls against one another. And then by turning in only the right side, we can create dramatic straightening. And I could have done that with no cartilage. Actually, I did do that, but there's no additional cartilage there. All that's done with her actual nasal skeletal cartilage. There's no cartilage grafting in the straightening component. Now there's grafting in her tip, which you'll see later, but the middle vault has no cartilage added.
1 minute remaining.
This is what this looks like. So taking the right upper lateral off of the septum, and you'll see that that just wants to fall in. Taking the left upper lateral off the septum. Lowering the septum. The bony hump has already been mostly lowered just by rasping. And look at what's happening automatically. That right upper lateral wants to fall in and create the turn-in flap all by itself. So to me, that's a big deal. Septal extension grafts. I do love septal extension grafts. So that's something that I still use. It creates a super stable tip, just like Dr. Vassar said. That is sometimes a criticism. It's been called unnatural and overly stiff. I've seen other surgeons write, it takes all the fun out of rhinoplasty because it's too predictable where your tip is. I don't need any more fun. I got plenty of fun. But when you come back into this nose, could I have accomplished this with the columnar strut graft? Yeah, probably, it'd be great. But when I open her nose that's got a columnar strut graft in it to do a revision versus opening a nose that has this big chunk of cartilage in it, I'm happier when I have a big chunk of, it's a little present to my future self if I ever have to come back in here. So it's a stable construct and it's a little bit of insurance for someday down the road. So miscellaneous, I've drifted towards percutaneous osteotomies. It's nice because they're quick and they're more controlled. You do the weakest part of the nasal bone first, and then the nasal process, the maxilla. If you do the traditional endonasal osteotomy, you're doing the nasal process of the maxilla, which is the strongest part, and you get uncontrolled random fractures through the thin parts of the bone. Pain control, bupivacaine blocks at the end, scheduled acetaminophen for 2 days, breakthrough gabapentin. 95% of my patients are fine with that. I write narcotics once every 50 rhinoplasties. Liposomal bupivacaine, I've used it. It didn't make any difference. I've eliminated all the topical adhesives under my brown paper tape. Haven't seen any more skin reactions, and none of them have fallen off. Not any more rate than before. Maybe 1 out of 100 they'll say it came off in the shower or whatever, but no more than before. And the final one is 7-OPGA. I'm closing all my skin and alar reductions and everything. It's not inflammatory at all. It doesn't make any inflammation. It's much less inflammatory than 6-0, like fast gut or that kind of stuff. Handles extremely well. It's easy to remove. If you can't find 7-0, 6-0 is almost as good. With that, I think I'm right on the end at the time mark here. I thank you all for listening. I thank you all for inviting me. I'm going to make a presentation here. If you are able to come, we'll see how the COVID situation goes. But I do an annual aging phase course every year, it's kind of an advanced aging phase course. And this year it's September 25th and 26th, which will be lectures and cadavers, followed by a day of live surgery in my office. If you are interested, the email address for the course director is down there. The website is actually on the bottom, the green section there, but it's easiest just to email Karen directly and she'll get you hooked up. So thank you so much. I appreciate your attention.
All right, thanks, Dr. Nayak. Appreciate that. Do we want to hand this off to our moderators to ask the questions, Tanuj?
Sure. Yeah. I just want to make a quick comment that, Mike, that is just a tour de force lecture in rhinoplasty. Every time you speak about the nose, we're all listening. So thank you for that. Yeah, let's have the moderators give some questions out to Mike and to any of the other speakers.
I have a question from Dr. Sehji Srivastava, New Delhi. is asking, do we address the swollen turbinates at the time of open rhino and how? I think it's for Dr. Mike.
Yeah, I routinely outfracture turbinates. I mean, 100% of rhinoplasties outfracture the turbinates. When I did my ENT residency, we call it, without the rhinoplasty part, we do a septoplasty and turbs. And for whatever reason, we always did the septoplasty first, and then right before I finished the case, we'd outfracture the turbinates and send. That's backwards. You should outfracture them the very first thing you do, because then you have more room to work inside the nose. Like that, I had that epiphany maybe 10 years ago, and I thought, why have I for all these years been struggling in a narrow nasal passage and then outfracture at the very end? I don't do other turbinate reductions. So like, do I do submucous resections and turbinoplasties and radiofrequency? I don't do any of those things. If I'm a cosmetic practice. And so if the patient has a lot of functional issues going on, that's more for my otolaryngology colleagues. So I'll do an outfracture, and that's the end of what I do.
Okay, thank you.
Hello, everyone. There's a question from Dr. Rahman from Baghdad. When can a filler be used in an operated nose? Hello?
Yeah,
I think Dr. Debraj could, I don't know, he gave a lecture on.
Thanks, Pragati. Wonderful lecture, Mike. Thanks a lot for improving our understanding of what you've changed over the past 10 years. Putting in fillers in the nose, especially in an operated nose, is slightly riskier, as Dr. Rifkin spoke about it, because the anatomy is all disordered. However, we have used fillers in noses which have been operated for correcting minor changes. Sometimes how the nose feels is also very important. And what tends to happen post rhinoplasty is you might end up having a particularly thin nose, a particularly thin skin in the nose, and then you can feel the irregularities over the dorsum. And in those cases, it helps to sort of coat that. Something we also do surgically, we use a lot of morcellized cartilage. So if that doesn't work and you can still feel the bits and it's a little bit irregular, then possibly 6 months after surgery, we'll go in and put in just a little filler, but very carefully, because it can lead to complications.
There's one more question from Dr. Mohan Jagare, Mumbai. Is that asking, why no dynamic acid for the septum? It's for Dr. Mike.
There have been isolated case reports of tranexamic acid administered in error into a intrathecal line. So in those isolated case reports where tranexamic acid has been administered in error into an intrathecal catheter, there have been seizures. And so I'm unaware of a case report of local anesthetic with tranexamic acid injected anywhere in the body, creating seizures.
Okay.
But you could make the argument that since the septal circulation is so adept at bringing serum levels up very quickly and is kind of interconnected with the cerebral circulation, you could make the argument that maybe save your tranexamic acid for your intravenous, maybe save your tranexamic acid local for your external nasal skin envelope, and maybe skip it in the nasal septum.
From my side, I have got a question to you. After hemidermal suture, do you apply interdermal suture? If so, how do you apply it?
Yeah, so I do use, so it's important, again, this was for 20 minutes, it's hard to cover all of it, but
Yeah.
I'll do the hemidermal sutures first, and then that, again, since that involves a steel component, that's driving the excess down into the medial crus. So we do those divisions, allowing the medial crus to passively overlap, and then putting the medial crus back together strongly. At that point, the intradermal suture, that again, from this polygon concept tip work, that's done as a figure of 8, a 5-0 PDS figure of 8. And the nice thing about a figure of 8 is it helps auto level the two edges. It makes it, when you have a figure of 8 suture, it's harder for them to override one another. And so that's done with the 5-0 PDS figure of 8. And then we go ahead and either columnar strut or anchor it to the septal extension, but critically by leaving the caudal edges of the medial crura still facing away from each other, not bringing them together and cementing them together and obliterating the columnar space polygon.
So you apply the posterior aspect up of the crude, isn't it?
Ask it one more time.
But yeah, you apply this intradermal suture in the posterior aspect of cephalic portion of the crura.
Yes, exactly the same, right at the same space where the cephalic hemidomal suture was.
Okay,
Same place. You're welcome.
Okay, thank you. I have a question to Dr. Devraj, though it's a bit not related to this rhinoplasty. Have you tried thread to lift the chin for chin?
I've used the thread for multiple places. So we started using the threads first for the chin, first for the cheeks. Then we started using it for the nose. We've used it even to lift the lip. You can use PDO threads to lift the lip, but I've never used it for the chin. I've used it for the brows and I've used it for the under eye area, but I've never used it for the chin. I think Constantine will be the right person to answer that. Is Constantine around? I think he's there. Just one moment. Constantine, do you want to address that particular question?
Or if he's unable to, then, we can have Ryan or Mike address the question.
Sure.
Well, I personally don't use threads. For me, it would be genioplasty, either an implant or an actual osteotomy versus fillers.
I can actually see Constantine online, but he's not responding. So no, I don't have any experience with that. I'm sorry, Dr. Narmaya.
Okay, it's okay. Thank you.
I have a question for Dr. Nayak. So when are you still using transdermal sutures in any case, or it's only hemidermal now?
I mean, never say never, but I can't think of the last one that I've used. I can't think of, it's been years. I mean, tomorrow I'll probably use one.
And Mike, do you think that the hemidermal sutures create any negative effect on the valve?
No, if anything, it's better. It opens the external valve, as I showed you in that video.
External valve, right? But in terms of rotation of the internal valve, downstream effect on the internal valve?
No, because you've already done a cephalic trend. The internal valve is between the caudal edge of the upper lateral, the septum, and the floor. This is sitting outside of that whole external valve. So no, I've not seen any issues with it at all.
Great. Well, I think we're getting to the end here, and I know we've gone over time, so I want to thank everybody for keeping the spirit going and staying with us for the entire session. This has been an awesome learning session for me personally. I wanted to thank all the speakers from around the world on behalf of Debraj and myself and the rest of the leadership of global cosmetic surgery. Another successful event today. I think, Mike, we need to add one more personality to your long list. You've got Nose Ninja, the Neck Ninja. You're also the Count on Sesame Street, aren't you? So we can add that to the list.
I've got Mr. Bean a lot.
Mr. Bean.
Right.
Yeah.
Well, look, I can't wait until we can all meet in person again. Until then, this has been, a fantastic way for the world to get together casually on a Sunday morning. And so once again, thank you to everybody. And we look forward to the next event sometime soon.
Stay safe, everyone. Bye.
Okay, bye-bye.